Let us begin by understanding acid-base foundations. And we will start by learning how to convert laboratory values into word form so they actually make sense during interpretation. As we build on that, we apply the rule of the bees, which states that if pH and bicarbonate move in the same direction, it is metabolic. To make this clearer, we always draw arrows beside each value to visualize direction. When those arrows point down, it represents acidosis. When those arrows point up, it represents alkalosis. Respiratory imbalances do not have a B in the name, so they occur when values move in opposite directions or when bicarbonate is normal. And finally, we must know normal pH, bicarbonate, and carbon dioxide values, because everything in acid-base interpretation depends on recognizing what is normal and what is not. Now, moving on, we emphasize the importance of principle over memorization, because you should not memorize long lists. You should simply know the physiologic principles. This is essential because NCLEX tests understanding, not memorized lists. That is why select all that apply questions require principle-based thinking. For example, a key principle is that opioids cause sedation and central nervous system depression, which explains lethargy, flaccidity, reflex 1+ or hyporeflexia, and an obtunded mental state. And this is important because NCLEX avoids list-based recall since different sources vary. So principles remain the most reliable tool for safe decision-making. Next, we focus on the key rule that as the pH goes, so goes the patient, except for potassium. When pH goes up, the patient goes up, meaning there is increased excitability, except for potassium. And that is why alkalosis leads to hyperreflexia, ranging from 3+ to 4+, tachypnea, tachycardia, borborygmi, and even seizures. When pH goes down, the patient goes down, meaning there is decreased function, except for potassium, and that is why acidosis causes hyperreflexia, ranging from 0+ to 1+, bradycardia, lethargy, an obtunded mental state, paralytic ileus, and respiratory arrest. And the NCLEX critical point here is that potassium moves in the opposite direction of pH. As we continue, we move into critical bedside priorities. And the first is that acidotic clients are at high risk for respiratory arrest, so we must keep an ambu bag at the bedside. In contrast, alkalotic clients are at high risk for seizures and aspiration, so we keep suction at the bedside. And finally, we come to MAC Kussmaul, which reminds us that Kussmaul respirations occur in only one acid-base disorder, and that is metabolic acidosis, because MAC stands for metabolic acidosis. As we begin exploring select all that apply questions, the first thing I want you to remember is that the most common error is choosing one extra option. So as you work through these items, stop once you have selected the ones you know are correct. Keep reminding yourself to avoid could-be thinking. And here comes an important NCLEX caution, which is to avoid selecting none. Along with that, avoid selecting all. Now, as we move into causes compared with signs and symptoms, it is essential that you do not confuse the cause of an acid-base disorder with its manifestations. For example, diarrhea leads to metabolic acidosis, but once the client becomes acidotic, the bowels slow down, resulting in paralytic ileus. So always remember that the cause often produces the opposite of the later symptoms. As we continue, let us look at how to approach scenarios logically. If the scenario is a lung problem, then it is respiratory. The next step is to determine if the client is overventilating, which would indicate alkalosis, or you need to see whether the client is underventilating, which would indicate acidosis. And remember that ventilation refers to gas exchange, not just the respiratory rate. That is why a high rate with low oxygen saturation means the client is underventilating, which leads to acidosis. And whenever you see a PCA pump concern, think respiratory acidosis due to respiratory depression. Continuing with the scenario method, if it is not a lung scenario, then it is metabolic. When you think of metabolic alkalosis, the only major scenario to look for is prolonged gastric vomiting or suctioning. This happens because of the loss of hydrochloric acid. It is commonly seen in conditions like gastrointestinal surgery, with nasogastric suction, and in hyperemesis gravidarum. And everything else that is non-lung will default to metabolic acidosis. Some examples include dehydration with hyperemesis, acute renal failure, and infant diarrhea. Finally, remember that there are only 4 acid-base choices, which are respiratory alkalosis, respiratory acidosis, metabolic alkalosis, and metabolic acidosis. When choosing between them, focus on modifying phrases, not just the main noun. For example, an obsessive-compulsive disorder client who is now psychotic should be guided by the psychosis as the priority. And when you see hyperemesis with dehydration, the dehydration is the key modifier. Before moving to the next topic, here's some great news for you. If you're feeling confused about what to study, or how to prepare effectively for the NCLEX, you're not alone. To support serious NCLEX aspirants, we're providing 30 days of completely free NCLEX study content on WhatsApp, which includes high-yield PDF notes, exam-focused concepts, daily practice questions, and clear, structured guidance. There is no payment required and no commitment involved. This is 100% free study support designed to help you prepare the right way. Simply click the WhatsApp link given in the video description and the channel bio. Send, "Hello, I want to join the 30-day free NCLEX study content program." Our team will share NCLEX study content with you regularly for the next 30 days. Now, let's move on to the next topic. Here we begin by understanding that it is essential to understand ventilator alarm systems. As we continue, we remind ourselves that the machine is set to maintain safe pressure limits. Then we emphasize that alarms indicate problems with airflow resistance or disconnection. Now, moving on, we explain that a high-pressure alarm indicates increased resistance to airflow. Following that, we clarify that the ventilator is pushing too hard to deliver air to the lungs. And finally, we note that common causes include obstructions. As we continue with obstruction-related causes, we state that kinks in tubing should be straightened or unkinked. Next, we explain that water condensation in the circuit should be emptied. After that, we note that mucus secretions require repositioning first, encouraging coughing and deep breathing, and then suctioning as needed. And we end this slide by highlighting the NCLEX priority, which is to check for kinks before suctioning. Moving forward to low-pressure alarms, we explain that this indicates decreased resistance to airflow. Then we clarify that the ventilator is working too little to push air. And finally, we note that common causes include disconnections. To conclude, we state that the main ventilator tubing being disconnected must be reconnected immediately. And lastly, we explain that oxygen sensor tubing, which is the black-coated wire near the airway or tracheostomy, must also be reconnected if it becomes disconnected. To begin, when we look at ventilator management and blood gases, we start by recognizing that respiratory alkalosis means the ventilation may be too high, which indicates the client is being overventilated. Continuing from there, respiratory acidosis means the ventilation may be too low, showing that the client is being underventilated. As we move into weaning considerations, we remind ourselves that we must not underventilate during weaning because inadequate ventilation can compromise the client's stability. Building on that idea, overventilation suggests that the client may actually be ready for weaning. Now shifting into an essential NCLEX safety reminder, never choose an option where the nurse does nothing and waits for someone else to act. Instead, always select the answer where you intervene directly within the nursing scope. Moving into psychological dynamics in abuse, the key concept here is that the primary psychological problem in all abusive situations is denial. To expand on the nature of denial, abusers have an infinite capacity for denial, and this allows continuation of the behavior without accountability. Continuing in the same sequence, denial is the #1 problem in child abuse, gambling, substance abuse such as cocaine use, alcoholism, and many more abusive patterns. And finally, from an NCLEX perspective, you cannot treat a client who denies they have a problem. As we begin understanding denial, remember that denial is the refusal to accept the reality of a problem. In the NCLEX setting, it becomes critical to identify whether denial is related to abuse or whether it is related to loss and grief. When treating denial in cases of abuse, the key strategy is to confront the problem. To do this effectively, we focus on the discrepancy between what the individual says and what the individual does. It is important to remember that confrontation is not aggression. Aggression attacks the person, while confrontation simply addresses the problem. In therapeutic communication, we avoid bad pronouns that create attack statements, such as starting with you. Instead, we use good pronouns that create therapeutic statements, such as beginning with I or we. For example, the wrong approach would be saying, "You wrote the order wrong," while the right approach is saying, "I am having difficulty interpreting what you want." When we look at denial in loss and grief, denial must be supported. This follows the DABDA sequence, which moves from denial to anger to bargaining to depression and finally to acceptance. Therefore, the NCLEX rule is simple. When it is loss, we support, and when it is abuse, we confront. As we move into psychological problem number 2, dependency and codependency, we begin with dependency. In dependency, the abuser gets the significant other to do tasks or make decisions, meaning the dependent person is actually the abuser. In codependency, the significant other gains self-esteem by doing things for the abuser. As a result, the abuser avoids responsibility, and the significant other remains due to that self-esteem reinforcement. As we begin treating dependency and codependency, the first important point is that we must set limits and enforce them. Next, we teach the significant other to say no consistently, emphasizing that their consistency is the key to breaking the unhealthy cycle. Then, we focus on building the self-esteem of the codependent person so they can feel empowered instead of obligated. Finally, we reinforce the powerful mindset shift expressed in the statement, "I am a good person because I am saying no," helping them internalize healthy boundaries. When we look at manipulation, we define it as the abuser getting the significant other to do things that are not in their best interest. It is important to recognize that this usually involves dangerous or harmful requests that place the other person at risk. As we compare manipulation with dependency, we see that both involve an abuser getting someone else to do something. The difference becomes clear when we consider the nature of the request. A neutral request points toward dependency or codependency. In contrast, a harmful or dangerous request indicates manipulation. When treating manipulation, we once again set limits and enforce them, making sure the response is a clear no. Interestingly, manipulation is easier to treat than codependency. This is because there is no self-esteem reinforcement involved, and people do not like being manipulated, which makes change more straightforward. For NCLEX clarity, denial always involves one client. Dependency and codependency involve two clients. Manipulation, however, involves just one client. As we begin this topic, remember that Wernicke's refers to encephalopathy, and Korsakoff's refers to psychosis, which is essentially a loss of reality. Although these conditions are typically separate, the exam often groups them together, and that is because they often occur in the same client. Now, moving deeper, this syndrome is understood as psychosis induced by vitamin B1, also called thiamine, deficiency. This deficiency leads to loss of reality due to a lack of vitamin B1. The primary symptom to remember is amnesia with confabulation, meaning the client makes up stories and believes them. As we shift to therapeutic management, the key is to avoid confrontation, because the client truly believes their stories. Instead of challenging them, you use redirection to guide their behavior toward achievable tasks. Looking at core characteristics, this condition is preventable through vitamin B1 supplementation. It is also arrestable, meaning its progression stops with vitamin B1. Unfortunately, it is irreversible in 70% of cases. Importantly, clients do not need to stop drinking for prevention or arrest. Finally, when we look at alcoholism treatment, disulfiram, also known as antabuse, is used as aversion therapy because it causes severe illness if alcohol is consumed. This reaction occurs when alcohol is in the bloodstream. The onset and duration are important. It takes 2 weeks before the effect begins and 2 weeks before the effect ends. And if a client plans to resume alcohol use, they must wait 2 weeks after stopping the drug. Let us begin by reviewing essential disulfiram teaching. And the first point is to avoid all sources of alcohol. This means clients must avoid mouthwash, aftershaves, and colognes. They must also avoid perfumes and insect repellents. They need to be careful with over-the-counter medications ending in the word elixir. They must avoid alcohol-based sanitizers. And finally, they should avoid uncooked icings that contain vanilla extract. Even red wine vinaigrette must be avoided to prevent a dangerous reaction. Now, moving forward, remember that every abused drug is either an upper or a downer. The exception to this concept is laxatives, which are the most commonly abused non-upper and non-downers among elderly adults. Next, we discuss uppers, and there are 5 main substances in this category. These include caffeine. They also include cocaine. Another group is PCP and LSD, which fall under hallucinogens. The next upper is methamphetamines. And the last one is Adderall. The signs associated with uppers include euphoria, tachycardia, restlessness, irritability, diarrhea, borborygmi, hyperreflexia, spasticity, and seizures. And during seizures, you must be prepared with suction. Now let us shift to downers. And the rule is that anything not an upper is considered a downer. The signs of downers include lethargy, respiratory depression, and respiratory arrest. Finally, let us look at the patterns of overdose versus withdrawal. And remember that overdose or intoxication simply means too much. Withdrawal, on the other hand, means not enough. When there is an upper overdose, everything goes up. When there is a downer overdose, everything goes down. When there is an upper withdrawal, everything goes down. And when there is a downer withdrawal, everything goes up. Let us begin by looking at the key priority patterns that guide NCLEX decision-making. Respiratory depression or arrest is most commonly linked to a downer overdose, and this helps us immediately identify the direction of symptoms. In contrast, upper withdrawal is also associated with respiratory issues, but in a different way that the NCLEX often expects you to distinguish. When we shift to seizure risk, the pattern flips again because seizure risk occurs with an upper overdose. And finally, seizure risk also appears during downer withdrawal, completing the predictable pattern that helps you choose the safest answer on the exam. Now moving into drug abuse in newborns, the most important NCLEX rule is that at birth, you always assume intoxication and not withdrawal. As time progresses, withdrawal begins after 24 hours, which dramatically changes how the newborn will present. When withdrawal involves a downer substance, you will see downer withdrawal signs such as an exaggerated startle, seizures, and a high-pitched cry. These predictable signs help you understand exactly what the exam is testing. As we shift into comparing alcohol withdrawal syndrome with delirium tremens, the first thing to remember is that both are different conditions. AWS begins 24 hours after the last drink, which means timing is essential for accurate identification. Only a minority of clients will go on to develop delirium tremens, so it is not expected in everyone. DT typically occurs around 72 hours, reinforcing the importance of the timeline. AWS always precedes DT, but delirium tremens does not always follow AWS, which is a major NCLEX distinction. AWS itself is not life-threatening, whereas DT can kill, making it a critical safety alert. And finally, AWS clients are not dangerous, while DT clients are dangerous, guiding the way we prioritize and manage care. Continuing into the expected symptoms, both conditions involve upper-type symptoms, because downer withdrawal causes everything to go up. DT clients, however, are unstable and require higher-level monitoring, which the NCLEX consistently expects you to prioritize. Finally, let us look at the care differences between AWS and DT, starting with diet and room assignments. Clients with AWS can receive a regular diet, and they can stay in a semi-private room anywhere on the unit, reflecting their lower risk. In contrast, clients with DT must be placed NPO or on clear liquids because of seizure and aspiration risk, and they require a private room near the nurse's station for safety and close monitoring. As we move into understanding care differences, let us start with mobility and restraints. In alcohol withdrawal syndrome, the client is up ad lib, meaning they can move around freely. They also require no restraints. However, in delirium tremens, the client must be kept on bed rest with no bathroom privileges. In this situation, we use 2-point locked leather restraints. These restraints are applied to the opposite arm and leg, and they must be rotated every 2 hours. And when managing restraints, we always lock the free limbs first before unlocking the secured limbs, following proper safety sequence. Now, as we continue, let us look at the medications for alcohol withdrawal syndrome and delirium tremens. Both types of clients receive antihypertensives, both receive tranquilizers, and both receive a multivitamin with vitamin B1. Each of these medication categories is essential and remains consistent across both conditions. Next, let us discuss nursing assignment considerations. A registered nurse can accept both alcohol withdrawal syndrome and delirium tremens clients. A licensed practical nurse cannot care for a delirium tremens client because it is considered an unstable condition. The registered nurse workload must be reduced when caring for a delirium tremens client. And board exams always assume ideal staffing when asking these types of questions. Moving forward, let us shift into aminoglycosides. These are powerful antibiotics used only when other treatments fail. They are high-risk medications frequently tested on the NCLEX for safety. A helpful memory aid is amine old mycin. This reminds us that aminoglycosides treat serious, life-threatening, resistant gram-negative infections. Most of these medications end in mycin. However, erythromycin, azithromycin, and clarithromycin are not aminoglycosides, despite the similar endings. Finally, let us review the major toxic effects of aminoglycosides. The first is ototoxicity. And we remember this with mycin equals mice equals ears. We monitor for hearing loss, tinnitus, and vertigo. The second major effect is nephrotoxicity. And we connect this because the ear resembles the shape of a kidney. We monitor creatinine because it is the best indicator of renal function. And if both testing options are available, we choose the 24-hour creatinine clearance over the serum creatinine. A few important reminders are that aminoglycosides are toxic to cranial nerve 8, and they are typically administered every 8 hours. Let us begin by looking at the routes and oral use of these medications. And first, I want you to remember that the preferred routes are intravenous or intramuscular. Now, because these drugs are not absorbed systemically when given by mouth, we say do not give them orally. This happens because the medication simply passes through the gut and is excreted without any effect. However, there are two important oral exceptions, which we call bowel sterilizers. The first exception is in hepatic encephalopathy, where the drug helps reduce ammonia levels by killing gut bacteria. The second exception is during preoperative bowel surgery, where it helps remove gram-negative flora. Even when used orally, these forms do not cause ototoxicity or nephrotoxicity. The key drugs used for this purpose are neomycin and kanamycin. And to help you remember this easily, just think of the phrase, "Who can sterilize my bowels?" Neo can. Before moving to the next topic, here's some great news for you. If you're feeling confused about what to study, or how to prepare effectively for the NCLEX, you're not alone. To support serious NCLEX aspirants, we're providing 30 days of completely free NCLEX study content on WhatsApp, which includes high-yield PDF notes, exam-focused concepts, daily practice questions, and clear, structured guidance. There is no payment required and no commitment involved. This is 100% free study support designed to help you prepare the right way. Simply click the WhatsApp link given in the video description and the channel bio. Send, "Hello, I want to join the 30-day free NCLEX study content program." Our team will share NCLEX study content with you regularly for the next 30 days. Now, let's move on to the next topic. Now let us move into trough and peak levels, often referred to as TAP. TAP simply means trough, then administer, then peak. The purpose of this is to help us monitor drugs that have a narrow therapeutic window. This is important because there is only a small difference between the effective dose and the toxic dose. For example, a drug like furosemide has a wide therapeutic range, so TAP monitoring is not needed. On the other hand, a drug like digoxin has a narrow range, so TAP monitoring is required. And for aminoglycosides, you must remember that they always require TAP monitoring. Next, let us talk about when to draw trough levels. And this timing is consistent across all routes. The trough is drawn 30 minutes before the next dose, no matter the route. For sublingual medications, draw it 30 minutes before the dose. For intravenous drugs, again, draw it 30 minutes before the dose. For intramuscular medications, the timing is still 30 minutes before the dose. For subcutaneous medications, the timing remains 30 minutes before the dose. And even for oral medications, you will draw it 30 minutes before the dose. Now, let us look at when to draw peak levels. And here the timing depends on the route, not the drug. For sublingual medications, we draw the peak 5 to 10 minutes after the medication has dissolved. For intravenous drugs, we draw the peak 15 to 30 minutes after the infusion completes. And if two answers seem correct, you should choose the latest time without going over. For intramuscular medications, the peak is drawn 30 to 60 minutes after administration. For subcutaneous medications, the timing is variable, applying mainly to insulin, and it is not tested here. For oral medications, peak levels are not tested because of their variability. Finally, let us finish by reviewing the Big 10 drug categories that you must know for the NCLEX. These include psych drugs, they include insulins, they include anticoagulants, they include digitalis, they include aminoglycosides, they include steroids, they include calcium channel blockers, they include beta blockers, they include pain medications, and they include obstetric medications. As we begin exploring cardiac drugs, Calcium channel blockers act like Valium for the heart. And this simply means they calm the heart. They are not stimulants. In other words, these medications are used to rest the heart. They create negative inotropic, chronotropic, and dromotropic effects. And that means they weaken, slow, and calm cardiac activity. Moving forward, positive inotropes stimulate and speed up the heart. In contrast, negative inotropes depress, calm, weaken, and slow the heart. When we talk about positive or negative chronotropes, we are referring to how they affect heart rate. And when we talk about positive or negative dromotropes, we are describing how they affect conduction speed. Now let us look at when we actually want to depress the heart, starting with antihypertensive use. These drugs relax the heart and vessels to lower blood pressure. The next use is anti-angina. They reduce oxygen demand to help relieve angina. The third use is anti-atrial arrhythmia. This includes atrial flutter, atrial fibrillation, and premature atrial contractions. And remember, these are never used for ventricular arrhythmias. Supraventricular tachycardia comes from an atrial origin and is treated by calcium channel blockers. As we consider side effects, the classic pair to remember is H and H, meaning headache and hypotension. Hypotension occurs because of vasodilation. Headache occurs because of cerebral vasodilation. And here is an NCLEX hint. Headache commonly appears in select all that apply questions. Finally, drugs ending in dipine, such as amlodipine or nifedipine, belong to this group. This category also includes verapamil and cardizem, also known as diltiazem. And cardizem may even be administered as a continuous intravenous drip. Let us begin by reviewing the assessment you must perform before giving a calcium channel blocker. And the first thing we always do is assess blood pressure. As we continue, remember that you must hold the medication if the systolic blood pressure is less than 100 millimeters of mercury. And if the client is on a cardizem intravenous drip, you need to monitor the blood pressure closely because you may need to adjust or even stop the infusion. Now let us move into cardiac arrhythmias and look at the key rhythm strips, starting with normal sinus rhythm, where you will see a P wave before each QRS and a T wave after. You will also notice that the spacing is even. Next, when you look at ventricular fibrillation, you will see a chaotic squiggly line with no pattern. Moving to ventricular tachycardia, you will observe sharp, repetitive peaks. And finally, in a systole, you will see a flat line. As we continue with rhythm terminology, remember that the QRS represents ventricular activity and the P wave represents atrial activity. Now, let us go through the 6 most tested NCLEX rhythms, beginning with the fact that a lack of a QRS means asystole. Then, when you see the presence of a P wave, you know you are dealing with an atrial origin. If you see a sawtooth pattern, that is atrial flutter. When the rhythm looks chaotic and there is also a P wave, that points to atrial fibrillation. When the rhythm is chaotic along with a QRS complex, that indicates ventricular fibrillation. If the rhythm looks bizarre and contains a P wave, that suggests atrial tachycardia. And when it looks bizarre with a QRS complex, that means ventricular tachycardia. Finally, let us talk about premature ventricular contractions. These are characterized by wide, bizarre QRS complexes, and they have a ventricular origin. When you see a group of PVCS, that indicates a short run of ventricular tachycardia. And in most situations, they are generally a low priority. However, they increase to a moderate priority if there are more than 6 PVCS per minute, more than 6 PVCS in a row, or if a PVC falls on the previous T wave, which is known as the R on T phenomenon. And a common medical order in these cases is to discontinue monitoring. As we begin this section on lethal arrhythmias, it is important to understand that these are high-priority rhythms that can be fatal in less than 8 minutes. This includes asystole and ventricular fibrillation. Both of these rhythms result in no cardiac output, and therefore no brain perfusion. Now moving into ventricular tachycardia, this rhythm is considered potentially life-threatening. It still produces cardiac output, which is why it is less critical than ventricular fibrillation. However, any rhythm changes that occur without cardiac output remain equally dangerous. When we talk about treatment, premature ventricular contractions and ventricular tachycardia are managed using lidocaine or amiodarone. Lidocaine is used more commonly in rural settings. For supraventricular arrhythmias, which are atrial in nature, we follow the ABCD approach. A stands for adenocard or adenosine. This medication is given as a rapid intravenous push in less than 8 seconds, followed immediately by a flush. It should be administered through a large vein. It may cause a brief episode of asystole, which is expected. B stands for beta blockers, often recognized by the suffix LOL. They have negative inotropic, chronotropic, and dromotropic effects. They also have similar effects as calcium channel blockers. They should be avoided in asthma and chronic obstructive pulmonary disease due to the risk of bronchoconstriction. C stands for calcium channel blockers. They have the same effects and indications as discussed earlier. D stands for digitalis, also known as digoxin or lanoxin. For ventricular fibrillation, the intervention is to defibrillate, because we always defib for VFib. For asystole, the first intervention is epinephrine, followed by atropine. As we begin this topic, let us first understand the core purpose of chest tubes. Chest tubes re-establish negative pressure in the pleural space so the lungs can expand. And this is essential because the pleural space normally maintains negative pressure that keeps the lung expanded. When there is an injury such as a gunshot, it introduces positive pressure, and that positive pressure causes the lung to collapse. Now, moving forward to a key NCLEX hint, we must always identify why the chest tube was placed. If the cause is a pneumothorax, the goal is to remove air. If it is a hemothorax, then the purpose is to remove blood. And if it is a pneumohemothorax, the chest tube is placed to remove both air and blood. Next, let us talk about how tube location matters. When a chest tube is placed apically, or high, its purpose is to remove air because air rises. And what becomes abnormal in this location is either no bubbling or draining large amounts like 200 milliliters. In contrast, when the tube is placed basilar, or low, its job is to remove blood or fluid by gravity, and abnormalities here would include bubbling or no drainage at all. Now let us walk through some chest tube placement scenarios. In a unilateral pneumohemothorax, there will be 2 tubes, with an apical tube for air and a basilar tube for blood. In a bilateral pneumothorax, there will be 2 apical tubes, one on each side. For postoperative chest surgery, there will be both an apical and a basilar tube on the surgical side. And unless it is clearly stated as bilateral, we always assume that surgery or trauma is unilateral. Finally, here is a classic NCLEX trick question. After a postoperative right pneumonectomy, there are no chest tubes. The rationale is simple. The lung has been removed, meaning there is no pleural space and therefore no pressure that needs to be re-established. Here's how I would explain this slide smoothly on camera. I would begin by saying that if the drainage system accidentally tips over, the first thing you need to do is simply set it upright. After repositioning it, you then ask the client to take deep breaths to help re-establish normal intrathoracic pressure. And it is important to remember that this situation is not a medical emergency, so staying calm and correcting the position is usually all that is needed. Now, moving to the next slide, when the water seal actually breaks and the device itself is damaged, the first thing you should do is clamp the chest tube, which prevents air from entering. After clamping, you then cut the tube away from the broken device. Once that is done, you place the open end of the tube into sterile water. After that, you unclip or unclamp the tube because the water now restores the water seal. And the key point is that it is always better to place the tube underwater than to leave it clamped. As we move forward, the slide now focuses on a very important NCLEX trick that compares the words first and best. When the question says first, it refers to the order of steps. When it says best, it is asking for the single most effective action. Using the water seal break as the example, the first action is to clamp the tube, but the best action is to place the tube in sterile water, because that actually restores the function of the system.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
On the next slide, we look at what to do when the tube is pulled out. The first action is to immediately cover the site with your gloved hand to prevent air from being sucked in. The best action is to apply Vaseline gauze, which creates an air-occlusive dressing and protects the client from developing a pneumothorax. Finally, the last slide reminds us how to interpret bubbling. You always begin by asking where it is bubbling. Then you ask when it is bubbling. And for NCLEX, remember that bubbling can be normal or abnormal depending on both of those answers. Let us begin by looking at bubbling patterns, starting with the water seal chamber, where intermittent bubbling is considered good. As we continue, you will notice that continuous bubbling in the water seal chamber is bad because it indicates an air leak. And in that situation, we must locate and tape the leak. Now, moving into the suction control chamber, intermittent bubbling here is bad, and we need to increase the suction until the bubbling becomes continuous. In contrast, continuous bubbling in the suction control chamber is good and expected. And a simple tip to remember is that both chambers operate in opposite patterns. As we shift to comparing thoracentesis and chest tubes, remember that thoracentesis involves in and out removal just like a straight catheter. Meanwhile, a chest tube is a continuous system much like a Foley catheter. And because continuous systems remain in place, they naturally carry a higher infection risk. Now, let us go over the clamping rules, beginning with the fact that we should never clamp a chest tube longer than 15 seconds without a provider order. Next, we use rubber-tipped double clamps to make sure we avoid damaging the tube. And during emergencies, you have about 15 seconds to get the tube underwater for safety. Moving into congenital heart defects, every congenital heart defect is either classified as trouble or no trouble. There are no in-between defects because each one either causes major issues or minimal issues. And the easiest way to remember this concept is to memorize the keyword TROUBLE. Now let us compare the key differences, beginning with trouble defects, which make up 95% and require surgery now in order for the child to live. These children experience slow and delayed growth and development. They also face a short life expectancy. Families dealing with these defects often experience high stress, grief, and a significant financial burden. These infants are discharged with an apnea monitor. They typically have a long neonatal hospital stay that lasts for weeks, and they are followed by a pediatric cardiologist. On the other hand, no trouble defects do not require immediate surgery. These children have normal growth and development. They also have a normal life expectancy. Families in these situations face routine challenges rather than severe stress. These infants do not require an apnea monitor. Their hospital stay is usually between 24 to 48 hours, and they are followed by a pediatrician or a pediatric nurse practitioner. As we begin discussing shunting and cyanosis, it is important to understand that trouble defects involve shunting from right to left, meaning from R to L, and these children are cyanotic or blue. In contrast, no trouble defects involve shunting from left to right, meaning from L to R, and these children remain acyanotic. Now, when it comes to the parent teaching strategy, remember that when teaching parents, we should select all options that indicate trouble if the defect is high risk. Boards do not ask you to diagnose defects, and that is why the nursing role is to teach the implications. If the defect is classified as trouble, then we prepare parents for significant challenges, and if the defect is classified as no trouble, then we reassure them that issues are minimal. Moving into the shortcut for identifying trouble defects, it helps to know that there are more than 40 congenital defects, so you do not need to memorize them all. The rule to remember is that any congenital heart defect starting with the letter T is considered trouble. The NCLEX focus is on implications, not on memorizing anatomy, and the nursing priority is simply to understand what to teach parents. Next, let us look at what all children with congenital heart disease have, whether they are trouble or no trouble. All of them have a murmur because blood is shunting in some direction. All of them get an echocardiogram to confirm the defect or to evaluate the murmur. Finally, when we talk about tetralogy of Fallot and its 4 defects, we use the mnemonic varied pictures of a ranch. VD stands for ventricular defect, PS stands for pulmonary stenosis, OA stands for overriding aorta, and RH stands for right hypertrophy. This is the only congenital defect where the NCLEX may ask you to identify the components, and you do not need to recall them from memory. You simply need to recognize them when you see the initials. As we begin, let us talk about recall versus recognize as an NCLEX strategy. And first we say that recall is simply retrieving information from nothing. Then we explain that recognize means identifying the correct pattern or initials in a question, which shifts the focus from memory to interpretation. And finally, we emphasize that the NCLEX expects recognition, not memorization of all 40+ defects. So your goal is pattern recognition, not memorizing endless lists. Now moving into infectious disease and precautions, we start with the idea that standard precautions form the foundation for all patient care. From there, we add that universal precautions reinforce this baseline level of safety for both the nurse and the patient. Then we introduce transmission-based precautions, which include contact, droplet, and airborne, and these must be applied based on how an infection spreads. As we continue, let us look at when contact precautions are indicated, beginning with the fact that they are required for enteric infections that spread by the fecal-oral route. Then we list the organisms, including Clostridioides difficile, hepatitis A, cholera, and dysentery. Next, we highlight the easy memory hint that bowel equals vowel, meaning hepatitis A is associated with the anus, while hepatitis B is associated with blood. And following that, we explain that contact precautions are also required for staphylococcal infections, respiratory syncytial virus, and herpes infections including shingles, also known as herpes zoster. Moving deeper into RSV, we begin by clarifying that RSV spreads primarily by droplets. Then we acknowledge that young children often spread it by touching contaminated surfaces. Even with that, we still place these patients on contact precautions. Next, we note that we cohort only confirmed RSV cases and not suspected cases. And finally, we confirm that a positive culture is needed because symptoms alone are not enough. And now, let us walk through the required measures for contact precautions, starting with what we must do, which includes wearing gloves. Then we add that a gown is also necessary. We follow this by reinforcing the importance of hand hygiene. After that, we mention that dedicated equipment such as a blood pressure cuff, stethoscope, and toys must be used. We continue by saying that disposable supplies should also be provided. Then we shift to what is not required, beginning with a mask unless a standard precaution requirement calls for it. Next, we explain that an eye or face shield is not routinely required. We also clarify that no special filter mask is needed, and we add that negative airflow is not part of contact precautions. Finally, we describe the room setup, stating that a private room is preferred but not mandatory, and that 2 confirmed RSV cases may be cohorted together. To begin, droplet precautions are required for organisms transmitted by large droplets within 3 feet. This includes all forms of meningitis. It also includes Haemophilus influenzae type B, also known as H-flu. H-flu is a major cause of epiglottitis. And when caring for a client with suspected epiglottitis, we do not place anything in the throat because of the risk of obstruction. Now, let us move into the required measures for droplet precautions. Yes, we must use a mask. Yes, we must use gloves. Yes, we must perform hand hygiene. The patient should also wear a mask when leaving the room. And disposable supplies and dedicated equipment must be used. Next, here are the items that are not required under droplet precautions. No, a gown is not required. No, an eye or face shield is not required. No, a special filter mask is not required. And no, negative airflow is not required. For room assignment, a private room is preferred, and on the NCLEX, you should always select the private room. Cohorting is allowed only with confirmed positive cultures. Next, let us review the indications for airborne precautions. These include measles. They include mumps. They include rubella. They also include tuberculosis. And they include varicella, which is chickenpox. Now, let us discuss the required measures for airborne precautions. For the room, a private room is required. Negative airflow is required. And cohorting is allowed only if all cases are confirmed. For what we must use, yes, we use a mask. Yes, we use gloves. Yes, we use hand hygiene. An N95 or special filter mask is used only for tuberculosis. And the patient should wear a mask for transport, although transport is avoided when possible. For what is not used, no, routine gowns are not required. And no, routine eye or face shields are not required. Finally, note that tuberculosis is technically droplet, but for NCLEX, it requires airborne precautions. Finally, let us review PPE donning and doffing. PPE removal follows alphabetical order, meaning gloves, then goggles, then gown, then mask. PPE application follows reverse alphabetical order for the G's, meaning gown, then mask, then goggles, then gloves. As we begin this topic on crutches, canes, and walkers, remember that locomotion is a major functional area, and it is frequently tested on the NCLEX. As we move forward, our focus will stay on physical therapy teaching and the risk reduction safety principles that the NCLEX loves to assess. Now, let us look at measuring crutches for proper length, because this prevents nerve damage, which is an important NCLEX safety point. To get the correct length, you need 2 to 3 finger widths below the anterior axillary fold. Then you measure down to a point that is lateral and slightly in front of the foot. And if you ever see an option that measures from the axilla directly to the foot, you can confidently eliminate it. Next, let us move to the hand grip, which is adjustable. A proper fit means the client should have approximately a 30-degree elbow flexion. Now, as we continue, remember that crutch gaits come in 4 types. Their names generally match their movement pattern, and you must know which gait is used for which condition. Now, let us examine the 2-point gait. In this gait, you move one crutch and the opposite foot together. Then you move the other crutch and the opposite foot, and you can remember it easily by thinking of moving 2 things together. Let us begin with the 3-point gait. And to understand it clearly, remember that in this pattern, you move 2 crutches and the bad leg together. I like to say it as moving 3 things together, because that phrase helps you visualize the sequence. This gait is used when one leg is affected, making it a common pattern when only a single limb needs support. Now moving forward, let us look at the 4-point gait, where you move each crutch and each foot separately. This method is very slow, but at the same time very stable, making it ideal for clients who need maximum control. In fact, it provides the highest stability gait among all options. Next, we shift to the swing-through gait, which is used for non-weight-bearing conditions such as amputations. In this gait, the client plants the crutches and swings through without touching the injured limb down, allowing safe movement without bearing any weight on the affected side. As we continue, choosing the correct gait becomes easier when you first ask how many legs are affected. A simple rule to remember is even for even and odd for odd, which helps match the gait pattern to the client's condition. A 2-point gait is used for mild bilateral weakness, while a 4-point gait is used for severe bilateral weakness. A 3-point gait is appropriate when only one leg is affected. Finally, let us walk through some clinical selection examples. Early rheumatoid arthritis corresponds to a 2-point gait. A left above knee amputation requires a swing-through gait. A post-operative right knee replacement with partial weight bearing uses a 3-point gait. Advanced ALS calls for a 4-point gait. A left hip replacement with non-weight bearing status also uses a swing-through gait. Bilateral total knee replacement on day 1 with weight bearing allowed requires a 4-point gait, and bilateral total knee replacement at week 3 transitions to a 2-point gait. Here we are looking at how to safely use crutches on stairs, and the first thing I want you to remember is the phrase, up with the good, down with the bad. This means that when you are going up the stairs, you always lead with the stronger, good leg. And as we continue, you must also remember that crutches always move with the bad leg. This ensures stability and prevents shifting your weight incorrectly. Once again, we are reinforcing safe stair navigation with crutches, and just like before, we start with the phrase, up with the good, down with the bad. This repetition helps solidify the movement pattern. And finally, keep in mind that crutches always move with the bad leg, which keeps the weak side supported during stair climbing or descending. Now, let us shift into the safe use of walkers, and the first idea we emphasize is that you pick it up, set it down, and walk to it. This simple rhythm keeps the client steady and forward moving. As we continue, we remind learners that belongings should be tied to the sides and never the front so the walker does not tip forward. And for NCLEX clarity, it is important to know that NCLEX does not prefer wheels or tennis balls on the walker because they change the intended stability pattern. Before moving to the next topic, here's some great news for you. If you're feeling confused about what to study, or how to prepare effectively for the NCLEX, you're not alone. To support serious NCLEX aspirants, we're providing 30 days of completely free NCLEX study content on WhatsApp, which includes high-yield PDF notes, exam-focused concepts, daily practice questions, and clear, structured guidance. There is no payment required and no commitment involved. This is 100% free study support designed to help you prepare the right way. Simply click the WhatsApp link given in the video description and the channel bio. Send, "Hello, I want to join the 30-day free NCLEX study content program." Our team will share NCLEX study content with you regularly for the next 30 days. Now, let's move on to the next topic. Next, we move into psychiatry, focusing on delusions, hallucinations, and illusions, and how to differentiate neurosis, which is non-psychotic versus psychosis. This sets the foundation for understanding how NCLEX expects you to identify mental status differences. Finally, when approaching psychiatric questions, your very first decision is guided by a key NCLEX principle, and that is to always determine non-psychotic versus psychotic first. This single step matters because it determines treatment, communication style, prognosis, medications, length of stay, and even legal considerations, making it the most foundational choice before anything else. Let us begin by understanding the difference between non-psychotic and psychotic clients, because this foundation is essential for safe NCLEX decision-making. When someone is non-psychotic, they have insight and they are reality-based. They are aware of the problem and the effects it has on their life. They may have emotional or behavioral disturbances, but they are still rational. On the other hand, a psychotic client has no insight and is not reality-based. They do not believe they are sick. They may blame others. And even if they say, "I am sick," if they connect it to unreal causes like saying Martians made them ill, then they still have no insight. Now let us look at how treatment differs between non-psychotic and psychotic clients. For a non-psychotic client, we use standard therapeutic communication. This approach is similar to what we use with regular medical, surgical, pediatric, and obstetric patients. However, with a psychotic client, standard therapeutic communication does not work. Instead, they require specific strategies that are unique to psychosis. Next, let us clearly distinguish symptoms. A non-psychotic client has no delusions, no hallucinations, and no illusions. A psychotic client, however, has the presence of delusions, hallucinations, or illusions. And the appearance of any of these means the client has crossed into psychosis. To understand psychosis more thoroughly, remember that there are three major categories of symptoms. These include delusions. They also include hallucinations. And finally, they include illusions. Now let us define delusions and the major types you must recognize. A delusion is a false, fixed belief with no sensory component. There are several types of delusions. A paranoid delusion occurs when a client believes people are out to harm them. A grandiose delusion occurs when someone has a belief of superiority or greatness. And a somatic delusion occurs when the client holds a false belief about their body. Definition: false, fixed sensory perception. And I want you to hold that exact phrase in mind as we go on. There are 5 types, one corresponding to each sense. So think sight, sound, touch, taste, and smell. Auditory hallucinations are the most common, and importantly, the voices patients hear are often harmful. Visual hallucinations are the second most common, so after voices, we look for things seen that are not there. Tactile hallucinations are the third most common, meaning false sensations of touch come next in frequency. Gustatory hallucinations are rare, so taste is an uncommon false perception. Olfactory hallucinations are also rare, meaning false smells do not happen often. Definition: misinterpretation of real sensory input, which means the stimulus is actually present but is wrongly perceived. An illusion has a referent, so remember that something real is present in the environment to cause it. By contrast, hallucinations do not have a referent because nothing real is triggering the perception. NCLEX. Tip: if the test mentions something real in the environment, then you should choose illusion. After confirming psychosis, ask, what kind of psychosis is this patient experiencing? For NCLEX purposes, there are 3 types to consider. The first is functional psychosis. The second is psychosis of dementia. The third is psychotic delirium. Characteristics: the person can function in daily life. So despite psychosis, they maintain some level of everyday functioning. There are 4 conditions listed under this category. And the first is schizophrenia. The second is schizoaffective disorder. The third is major depression, the major type. The fourth is manic, in the acute phase. Note that bipolar is functional only in the manic psychotic phase. So bipolar disorder counts here only during that manic psychotic period. Importantly, individuals with functional psychosis can learn reality because there is no structural brain damage causing the symptoms. Use the 4-step reality teaching method, which gives us a clear sequence to follow. First, acknowledge feeling. Next, present reality. Then, set limit. Finally, enforce limit, which may include ending the conversation if needed. NCLEX. Note, choose the most positive, strength-based response when you answer questions about nursing actions. As we begin this topic, psychosis of dementia occurs due to actual brain damage. It includes conditions such as Alzheimer's, post-stroke psychosis, and organic brain syndrome. Because of this damage, the individual cannot learn reality. It is important to remember that forgetfulness alone is not psychosis. However, when hallucinations or delusions begin, that is when psychosis develops. Moving into the nursing role, the first step is to acknowledge the person's feeling. After acknowledging, we then redirect them to an appropriate activity. We do not set limits. We also do not present reality during psychotic symptoms. At the same time, reality orientation, including person, place, and time, is still appropriate for memory, but not for delusions or hallucinations. Now let us look at psychotic delirium, which is defined as a temporary, sudden, dramatic, episodic, secondary loss of reality. Common causes include drug reactions, intoxication, and withdrawal, such as delirium tremens. It can also occur as postoperative psychosis. Another cause is ICU psychosis. Infections, for example, a urinary tract infection, can also trigger it. Endocrine emergencies like thyroid storm may be a cause, and adrenal crisis is another possible source. Next, we discuss the nursing role in psychotic delirium, where we begin again by acknowledging the person's feeling. We then reassure them that it is temporary and that they are safe. We do not present reality. We do not redirect. The priority is to treat the underlying cause and to maintain safety. Finally, when we consider personality disorders, the high-risk types include antisocial, borderline, and narcissistic personalities. These individuals often require limit setting that is similar to the strategies used for functional psychosis. As we move into this topic, let us begin by understanding that loosening of associations refers to thinking that is not logically connected. Next, we identify the types, starting with flight of ideas, which means the person uses connected phrases but there is no logical sequence between them. Then we look at word salad, which occurs when the person speaks random, incoherent words. Finally, we consider neologisms, which are invented words created by the patient. Now, moving forward, narrowed self-concept is something that we commonly see in functional psychosis. In this condition, the patient may refuse to leave their room or refuse to change their clothes. Their identity becomes based on where they are and what they wear. In terms of nursing action, we must remember that we do not force changing clothes or leaving the room. Instead, we rely on functional psychosis techniques to guide our communication and interaction. Continuing ahead, ideas of reference occur when the patient believes that others are talking about them. This experience can coexist with paranoia. It becomes paranoia if the patient also believes that harm is intended toward them. As we summarize psychosis management, the first essential step is to identify the psychosis type. Once this is clear, we apply the correct communication strategy. Throughout this process, we maintain safety. And finally, we must know when reality teaching works, which is only in functional psychosis. Moving into diabetes mellitus, we define it as an error of glucose metabolism. Glucose is the primary fuel source, so impaired metabolism leads to cellular death. Diabetes mellitus does not include diabetes insipidus, which is polyuria and polydipsia, due to low antidiuretic hormone. The symptoms may look similar in terms of fluids, but they are not related to glucose. The opposite of diabetes insipidus is SIADH. Let us begin by understanding that urine output and specific gravity are inverse, and this simply means that as one rises, the other falls. When urine output is low, the specific gravity becomes high. When urine output is high, the specific gravity becomes low. In diabetes mellitus, the body produces excessive urine, so we see polyuria along with low specific gravity. In contrast, in syndrome of inappropriate antidiuretic hormone, we see low urine output with high specific gravity. Now let us look at the differences between type 1 and type 2 diabetes. Type 1 diabetes is insulin dependent. It has a juvenile onset. It is ketosis prone. Meanwhile, Type 2 diabetes is non-insulin dependent. It has an adult onset, and it is non-ketosis prone. As we move forward, let us review the classic signs and symptoms. Polyuria is a key finding. Polydipsia is also seen. Polyphagia, which means increased eating or swallowing, is present as well. And these same symptoms are seen in both type 1 and type 2 diabetes.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Next, let us focus on the treatment overview. For type 1 diabetes, we use the acronym DIE. Diet is considered the least important. Insulin is the most important. Exercise also plays a role. For type 2 diabetes, we use the acronym DOA. Diet is the most important. Oral hypoglycemics are added, and activity is emphasized. Finally, let us take a look at diet therapy. Diet therapy is primarily for type 2 diabetes. Calorie restriction is the best strategy. Eating 6 small meals per day helps keep glucose more stable and avoids large peaks. As we start with insulin basics, remember that insulin lowers blood glucose. For the NCLEX, you must know the 4 main types. Peaks are the moments of highest risk for hypoglycemia. And finally, only clear solutions can be given intravenously. When we talk about regular insulin, examples include Humulin R and Novolin R. The onset is 1 hour. The peak occurs at 2 hours. The duration lasts 4 hours. Because it is clear, it can be given intravenously. It is considered short or rapid acting, and HESI may even call it intermediate. NPH insulin is an intermediate-acting insulin. Its onset is 6 hours. Its peak occurs between 8 and 10 hours. Its duration is 12 hours. It is a cloudy suspension. It should never be given intravenously. And the general rule is to never put cloudy insulin in an IV. Lispro, also known as Humalog, is the fastest-acting insulin. Its onset is 15 minutes. Its peak is 30 minutes. Its duration is 3 hours. And it should be given with meals as the client begins eating. Lantus or Glargine is a long-acting insulin. It has no significant peak, which means there is a low risk of hypoglycemia. Its duration ranges from 12 to 24 hours. And it is the only insulin that is safe to give at bedtime. As we begin with insulin safety, always remember that we must always check the expiration before giving insulin. When we open the vial, the manufacturer expiration immediately becomes invalid, and it takes on a new 30-day expiry. Refrigeration is optional in the hospital, but it is required for storage at home, and warm, non-expired insulin is safer than cold, expired insulin. Moving into exercise, we emphasize that exercise potentiates insulin. This means that more exercise leads to less insulin being needed. We treat exercise like an extra dose of insulin, and we always advise clients to carry rapidly metabolizable carbohydrates during sports. Next, when we talk about sick day rules, remember that illness causes glucose to increase. Because of that, clients must continue insulin even if they are not eating. They should take frequent sips of water to prevent dehydration. Sick diabetics always risk hyperglycemia and dehydration, and they should remain as active as possible to reduce glucose. Now, let us move into an overview of acute complications, which include low blood glucose, also known as hypoglycemia. They also include diabetic ketoacidosis in type 1 diabetes. And finally, they include HHNK or HHS in type 2 diabetes. Finally, when we focus on hypoglycemia, the causes include not enough food, too much insulin, and too much exercise. And the real danger in hypoglycemia is permanent brain damage. As we move into hypoglycemia signs, I want you to remember that the overall appearance is often described as looking drunk and in shock. And this helps you immediately recognize it in real clinical settings. You may notice slurred speech, staggering, and impaired judgment. which can look very similar to intoxication. Along with that, the client often presents with low blood pressure, tachycardia, and cold, clammy skin, which are key indicators of sympathetic activation. Finally, there is a vasomotor and neurologic compromise, which explains the rapid decline you may see if hypoglycemia is not corrected quickly. Now, let us talk about hypoglycemia treatment. And the first action is to give a rapidly metabolizable carbohydrate, such as juice, soda, candy, milk, or honey, so that blood glucose can rise quickly. After that initial correction, you follow with a starch or protein like crackers or turkey to maintain stability and prevent another drop. Skim milk is especially helpful because it provides both carbohydrate and protein together. If the client is unconscious, the next step is to give glucagon intramuscularly or intravenous dextrose, such as D10 or D50. The choice between these options depends entirely on the setting, such as whether you are managing the client at home or in the emergency room. Moving forward to diabetic ketoacidosis in type 1 diabetes, it is important to understand that it can be caused by too much food, creating an overload of glucose that cannot be utilized. It can also occur from not enough medication, which means insulin levels are insufficient for metabolic needs. Not enough exercise can contribute to rising glucose as well, creating an imbalance. However, the most common trigger is a recent viral upper respiratory infection, which significantly increases metabolic stress on the body. Now let us look at the signs of DKA using the DKA memory tool. The D stands for dehydration, which is one of the most severe and visible symptoms. The K reminds you of ketones in the blood, small respirations, and high potassium levels, all of which signal metabolic instability. The A represents acidosis, specifically metabolic acidosis, along with acetone breath and anorexia or nausea that often accompany it. Clients may also have hot, flushed, dry skin, which helps differentiate DKA from hypoglycemia. To treat DKA, the first priority is rapid intravenous fluids to correct the severe dehydration. Once fluids are initiated, regular insulin is given through an intravenous infusion to reduce blood glucose and stop ketone production. As we begin with hyperosmolar hyperglycemic non-ketotic syndrome, or HHNK, commonly seen in type 2 diabetes, we need to remember that this condition is characterized by severe dehydration. While explaining this, it is important to note that there is no ketosis and no acidosis present in HHNK. Because of this profound dehydration, the nursing diagnosis we prioritize is fluid volume deficit. Therefore, the priority intervention becomes the administration of intravenous fluids. As treatment progresses, our desired outcomes include improved urinary output, rising blood pressure, and moist mucous membranes, all indicating that hydration status is stabilizing. Now, as we compare diabetic ketoacidosis with HHNK, it is essential to understand that insulin is most essential for managing DKA. Although HHNK carries a higher mortality rate, it is DKA that becomes more immediately life-threatening if untreated. However, DKA is usually treated early, which reduces the risk of complications. Moving into long-term complications of chronic hyperglycemia, these issues primarily occur due to poor tissue perfusion and peripheral neuropathy. Examples of these complications include renal failure, which results from poor perfusion. Another example is incontinence, which develops due to neuropathy. Loss of sensation is also a consequence of neuropathy. Finally, poor wound healing reflects ongoing poor perfusion. When discussing the best indicator of long-term diabetic control, we focus on hemoglobin A1C, also known as glycosylated hemoglobin. In terms of values, an A1C of 6 or lower reflects good control. An A1C of 8 or higher indicates poor control. A value of 7 is considered borderline and requires evaluation. For NCLEX purposes, always focus on the numbers rather than the units. Finally, as we turn to drug toxicity, remember that there are 5 major drug toxicities that are frequently tested on the NCLEX. These are often asked in safety-based questions. The NCLEX does not test units in these toxicity questions. Therefore, it is crucial to know the therapeutic levels versus the toxic levels clearly. Let us begin by looking at lithium and its key levels. Lithium is used for mania and bipolar disorder, and that is always our starting point. The therapeutic level is 0.6 to 1.2, and we must remember that clearly for NCLEX. The toxic level is anything greater than 2, which is an immediate red flag. The The range from 1.2 to 2 is often referred to as the gray zone, and that is because different books disagree about how to classify it. Since books disagree, NCLEX will not use gray zone values, which makes things much simpler for us. NCLEX tests only one rule: over 2 is toxic. Now let us continue by reviewing digoxin, also known as lanoxin, and its uses. It treats atrial fibrillation, which we remember from the ABCDs of atrial arrhythmia treatment, and it also treats congestive heart failure. Before giving this medication, you must check the apical heart rate before administration, and that is the critical safety step for NCLEX. Moving forward, let us look at the key levels for digoxin. The therapeutic level is 1 to 2, and that is the range NCLEX expects you to know. The toxic level is anything greater than 2, making elevated numbers very important to identify. The NCLEX safety tip is that if the value is 2, classify it as toxic, because that keeps the client safest during the exam. It is always safer to consider borderline values as toxic. Next, let us talk about aminophylline and its purpose. It acts as an airway antispasmodic, which means it targets spasm rather than dilation. It is not a true bronchodilator because it does not activate the beta-2 receptors. Instead, it relaxes airway muscle spasm so the airway widens. Finally, let us understand the clinical use of aminophylline. If bronchodilators fail during acute asthma due to severe spasm, then we give aminophylline first to relieve the spasm. Once the spasm relaxes, the bronchodilator becomes effective. As we begin this topic, let us first talk about aminophylline and its key levels, because knowing these values is critical for NCLEX safety. The therapeutic level is 10 to 20, which means this is the range where the medication works effectively without causing harm. The toxic level is anything greater than 20, and once levels cross this point, immediate intervention is required. Moving forward, let us now focus on Dilantin, also known as phenytoin. It is an anticonvulsant used for seizure control, and this is exactly how NCLEX expects you to remember it. The therapeutic level is 10 to 20, identifying the safe and effective range for the drug. The toxic level is anything greater than 20, which signals that the medication is no longer safe and requires urgent attention. Now, let us shift gears and talk about bilirubin by starting with the basics. Bilirubin is a waste product of red blood cell breakdown, and understanding this foundation helps you answer NCLEX questions more confidently. NCLEX tests bilirubin primarily in newborns, so always keep that population in mind. The normal adult bilirubin level is 1 to 2, which represents the expected range in healthy adults. Newborns naturally have higher levels, often 5 or more, and this elevation is considered a normal finding in early life. Continuing with bilirubin, let us look at the specific levels and what they indicate. The elevated but therapeutic range is 10 to 20, meaning levels may be high but can still be managed safely. For example, a bilirubin of 9.9 is high, but still acceptable, and this distinction often appears in NCLEX questions. The toxic level is anything greater than 20, and this is the point where serious complications become a concern. Medical doctors consider admission around 14 to 15 to prevent progression to the toxic range, ensuring early intervention. To complete our understanding, let us look at the types of jaundice. Pathologic jaundice is the first type, and it is present at birth, meaning the newborn shows high bilirubin and yellow skin immediately. Physiologic jaundice is the second type, where bilirubin is normal at birth, but it increases over 2 to 3 days, and yellowing gradually develops. As we move into this high-yield pattern hint, remember that 2L drugs like lithium and lanoxin or digoxin become toxic at a level of 2. And when we look at the others, such as aminophylline, dilantin, and bilirubin, their toxic level is 20. Now let us talk about kernicterus, where bilirubin crosses the blood-brain barrier. This condition typically occurs at levels around 20. It leads to aseptic meningitis. It also leads to aseptic encephalitis. It can be fatal. And it is important to remember that this is different from jaundice, which refers only to skin discoloration. Next, let us understand opisthotonos, which is a posture resulting from bilirubin toxicity in the brain. It presents as severe hyperextension due to meningeal irritation. A newborn may arch so far that the heels can touch the ears, and the infant becomes rigid, making this an emergency. Here we are, looking at a high-yield comparison of opposite gastric emptying issues. The core concept here is that both are gastric emptying disorders. They work as opposites, so you can memorize one to understand the other. And the NCLEX note reminds us that positioning changes, fluid content, and carbohydrate content directly affect emptying time. We focus on three modifiable factors: head of bed height, water content of meals, and carbohydrate content of meals. Let us begin with an important clinical side note that also serves as an NCLEX positioning reminder. For example, when you see an opisthetonic child, you should place them on their side, and this position prevents airway obstruction. As we look at the gastric emptying treatment table comparing hiatal hernia and dumping syndrome, let us begin by focusing on the key factor being discussed. The first factor shown is the head of bed, and for hiatal hernia, the instruction is to keep the head of the bed high during and after meals because gravity leads to faster emptying. In contrast, for dumping syndrome, the head of the bed should be kept low, or the client should lie flat, and they may even turn to the side while eating. Moving to the next factor, which is water content, the table explains that hiatal hernia requires high fluids, while dumping syndrome requires low fluids, meaning no fluids with meals, and fluids should be given 1 hour before or after eating. The next factor listed is carbohydrate content. And for hiatal hernia, the recommendation is high carbohydrates, while for dumping syndrome, the recommendation is low carbohydrates. Finally, the last factor shown is protein content. And hiatal hernia calls for low protein, whereas dumping syndrome calls for high protein. Now moving into the pathophysiology of a hiatal hernia, the key mechanism is that the upper stomach herniates upward through the diaphragm. As a result of this shift, it creates what we describe as a two-chamber stomach. Because of this abnormal structure, gastric contents begin to move in the wrong direction, meaning the rate is correct, but the direction is not. As we continue, remember that the symptoms of a hiatal hernia often mimic gastroesophageal reflux disease, presenting with heartburn and indigestion. The NCLEX critical distinction here is that GERD symptoms from a hiatal hernia occur only when the person is lying down after eating. This means that if the symptoms occur before lying down, then it is not a hiatal hernia. Ultimately, the presentation is dependent on both body position and meal timing. Finally, the treatment goal focuses on emptying the stomach faster. The reason is that faster emptying reduces the risk of reflux. To accomplish this, we follow the treatment table, which includes keeping the head of the bed high, maintaining high fluid intake, increasing carbohydrates, and lowering protein. Let us begin by understanding the basic mechanism of dumping syndrome. Gastric contents dump too quickly into the duodenum. This usually happens as a common effect after gastric surgery. And to simplify the concept further, the contents are moving in the right direction, but they are moving at the wrong rate because they are moving too fast. Now let us move into the major symptoms you must memorize for the NCLEX. A helpful way to remember this condition is through the phrase drunk plus shock plus abdominal distress. Starting with the neurologic or drunk-like symptoms, you will see slurred speech, staggering, impaired judgment, and delayed reactions, all of which occur due to decreased brain perfusion. Then you will notice the shock signs, which include hypotension, tachycardia, tachypnea, and pale, cool, clammy skin. Finally, you will see acute abdominal distress presenting as cramping, guarding, diarrhea, borborygmy, bloating, tenderness, and distension. Next, let us talk about what the NCLEX wants you to do for treatment. The goal is to slow gastric emptying, and to achieve that, you simply follow the treatment table that includes low head of bed, low fluids with meals, low carbohydrates, and high protein. Now, here is a very high-yield contrast that the NCLEX frequently tests. We look at opposite patterns. In hiatal hernia, the goal is to increase gastric emptying. In dumping syndrome, the goal is to decrease gastric emptying. And when it comes to the carbohydrate and protein rule, whatever carbohydrates do, protein does the opposite. To finish, let us reinforce the key electrolyte rules you must memorize. You need to remember 3 core sentences for signs and symptoms. Kalemias, meaning potassium imbalances, do the same as the prefix, except for heart rate and urine output. Calcemias, which refer to calcium imbalances, do the opposite of the prefix. And magnesemias, which involve magnesium imbalances, also do the opposite of the prefix. Finally, use arrows to map increased or decreased symptoms. Let us begin by understanding kalemia. And first remember that kalemias have symptoms that follow the prefix, where hyper means increased and hypo means decreased. The key exception you must always keep in mind is that heart rate and urine output go in the opposite direction of the prefix. So, when looking at hyperkalemia and hypokalemia, simply look at the prefix to predict the direction of the symptoms. Starting with the brain, hyperkalemia presents with irritability, agitation, restlessness, aggression, and a loud or boisterous behavior. In contrast, hypokalemia presents with lethargy, being obtunded, and progressing towards stupor. When we shift to the lungs, hyperkalemia leads to tachypnea, whereas hypokalemia causes bradypnea. Now, looking at the heart, hyperkalemia causes a low heart rate, peaked T waves, and ST elevation, while hypokalemia causes a high heart rate, meaning tachycardia. When we move to the bowel, hyperkalemia produces diarrhea and hyperactive bowel sounds, also known as borborygmi, while hypokalemia results in ileus and constipation. Looking next at the muscles, hyperkalemia causes spasticity and hyperreflexia, while hypokalemia leads to flaccidity and decreased reflexes. And finally, for urine output, hyperkalemia causes a low output, while hypokalemia causes a high output. Now, let us apply this to a sample NCLEX question strategy involving potassium by considering a scenario where your patient has hyperkalemia and you must select all that apply. The possible answers include dynamic ileus, obtunded, +1 reflex, clonus, a U wave, a depressed ST wave, polyuria, and bradycardia. And here's your NCLEX hint. If you are unsure, do not overselect options. Now moving into calcemias, remember that calcemias do the opposite of the prefix. So in hypercalcemia, the body goes low, producing bradycardia, bradypnea, lethargy, flaccidity, and constipation. Meanwhile, in hypocalcemia, the body goes high, leading to agitation, clonus, hyperreflexia, seizure, and tachycardia. Trousseau's sign is elicited when you inflate the blood pressure cuff and it produces a characteristic hand spasm. Chvostek's sign is elicited by tapping the cheek and causes a facial spasm. Both of these signs indicate neuromuscular irritability due to hypocalcemia. With magnesemias, remember that the magnesium level behaves opposite to the prefix. Hypomagnesemia can be associated with hypertension. Symptoms may overlap between potassium, calcium, and magnesium. Tiebreaker. Do not pick magnesium because it is the minor player. If the problem involves skeletal muscle or nerve, attribute it to calcium. Everything else you should attribute to potassium. Your patient has diarrhea. Possible causes are A. Hyperkalemia, B. Hypokalemia, C. Hypocalcemia, D. Hypomagnesemia. Use arrows to identify whether the symptom is increased or decreased. Draw direction arrows for clarity on your paper. If the symptom is not related to muscle or nerve, rule out calcium. In a tie, do not pick magnesium. Question. Your patient has tetany, which is an increased symptom. What is the cause? A. High potassium, B. High calcium, C. Low magnesium? Use prefix logic, then arrows, then the tiebreaker. Do not jump to calcium without first evaluating the direction. As we begin with sodium disorders, I want you to remember that hypernatremia is all about dehydration, while hyponatremia is all about fluid overload. When you think of these two conditions, think of the classic dehydration versus overload symptoms that help you distinguish them quickly. And in diabetic ketoacidosis, hypernatremia is possible because the client is severely dehydrated. Now moving into the early and universal signs, the earliest sign of any electrolyte imbalance is numbness and tingling, also called paresthesia. Circumoral paresthesia, meaning tingling around the mouth, becomes a very early indicator you should never ignore. And the universal sign you will see across most electrolyte disorders is muscle weakness, also known as paresis. When we talk about treating electrolyte disorders, NCLEX heavily tests potassium treatment because it is one of the most critical areas for client safety. High potassium is the most dangerous imbalance because it places the client at immediate risk for fatal arrhythmias. Now, let us review the potassium treatment rules, starting with the fact that you must never push potassium intravenously. The maximum amount allowed is 40 milliequivalents per liter of intravenous fluid, and you should always clarify any orders that go above 40. We also give dextrose 5% in water with regular insulin because this is the fastest method to lower serum potassium. This combination drives potassium into the cells temporarily, and it buys time to treat the actual cause. Finally, when we look at Kxalate, Remember that it is a sodium-rich medication that can be given orally or rectally. It works by exchanging sodium for potassium, so the patient can excrete the excess potassium. This process often leads to hypernatremia, which means dehydration can occur as a side effect. The major advantage of NCLEX is that it removes potassium permanently. However, its major limitation is that it works slowly over hours, and the patient may not be able to tolerate that delay. Let us begin by understanding the best NCLEX answer for dangerous hyperkalemia. In this situation, we use both D5W with regular insulin for the fast effect and NCLEX for the permanent effect. When these two are used together, this combined therapy becomes the safest and most effective correction. Now moving into our endocrine overview, the focus here is on the thyroid and adrenal glands. Remember this important NCLEX hint. Replace the word thyroid with metabolism, because the thyroid regulates metabolism. As we look at thyroid disorders, hyperthyroidism means hypermetabolism. In contrast, hypothyroidism means hypometabolism. When we discuss hyperthyroidism, here are the key signs. You will see weight loss. You will also see high blood pressure and a high heart rate. Anxiety, irritability, and hyperactive behavior are common. The client will have heat intolerance. You may also notice exophthalmos. This condition is known as Graves' disease. Now for treatment options for hyperthyroidism, we begin with radioactive iodine. Another option is PTU, which is propylthiouracil. And finally, thyroidectomy is the most common treatment. Let us begin by reviewing essential radioactive iodine care. And the first point is that the patient must be kept in a private room for the first 24 hours. Next, you need to remember that there should be no visitors during the first 24 hours. Then we focus on radioactive urine precautions. And the first of these is that the toilet must be flushed 3 times. Another key precaution is that hazardous materials protocols are required if urine is spilled. And finally, the nurse's greatest risk during this period is exposure to the urine itself. Now let us shift to PTU, or propylthiouracil. And the first thing to understand is that it puts the thyroid under and slows metabolism. Another important point is that PTU is also a cancer drug. We then acknowledge that PTU causes immunosuppression. And because of that effect, the nurse must monitor the white blood cell count. Moving forward to thyroidectomy types, we start with a total thyroidectomy, where the patient will require lifelong hormone replacement. Another essential point for total thyroidectomy is that there is a risk for hypocalcemia. Because of that risk, the nurse must check for Trousseau's and Chvostek's signs. Next, we look at subtotal thyroidectomy, where hormone replacement is only temporary. The subtotal procedure also carries a lower risk for hypocalcemia. However, a key distinction is that subtotal thyroidectomy carries a risk for thyroid storm, while totals never get this condition. As we now discuss thyroid storm, the first identifying feature is a temperature of at least 105 degrees Fahrenheit. Another critical symptom is severe hypertension. We also see tachycardia that can exceed the 180s. Additionally, psychotic delirium may occur, and we must emphasize that this is a medical emergency with a risk of brain damage. Finally, when we look at thyroid storm management, the priority is to decrease temperature and increase oxygen. The first intervention to achieve this is applying ice packs. The best cooling intervention is using a cooling blanket. At the same time, oxygen should be administered via mask at 10 liters per minute. It is important to note that you should not medicate in this situation. Managing this event requires 2 staff members for safety. And the last point is that thyroid storm is self-limiting, meaning it will resolve or become fatal if untreated. As we begin looking at post-thyroidectomy risks, remember that these are time-critical. In the first 12 hours after surgery, whether it is a total or a subtotal thyroidectomy, the greatest concerns are airway obstruction and hemorrhage. This is because the thyroid gland is highly vascular, making bleeding a major complication to watch for. Moving into the 12 to 48-hour window, the risks now depend on the type of surgery that was performed. After a total thyroidectomy, the major concern is tetany from hypocalcemia, which becomes an airway risk. After a subtotal thyroidectomy, the priority shifts toward the potential for a thyroid storm. When we move beyond 48 hours post-operation, the primary concern becomes infection. However, there is a major NCLEX warning here, because you should not choose infection as the priority within the first 72 hours. Now, as we focus on hypothyroidism, we remember that this condition represents hypometabolism. Clients often experience weight gain and obesity, along with fatigue and a flat effect. They are also prone to cold intolerance, and they commonly present with low blood pressure and a low heart rate. This condition is also known as myxedema. When it comes to treatment for hypothyroidism, the approach is thyroid hormone replacement. This is done by administering Synthroid, also known as levothyroxine. Let us begin by focusing on hypothyroidism NCLEX safety. And the first thing to remember is that we never sedate these patients because doing so places them at a high risk of developing myxedema coma. As we continue, you must always question any preoperative sedation orders for a client with hypothyroidism. Moving forward, if the patient is NPO before surgery, you must call the provider because thyroid hormone must still be taken even when the patient is not allowed oral intake. And finally, we never hold Synthroid without an explicit order, so always seek clarification before stopping it. Now, shifting into adrenal cortex disorders, we start by remembering that these diseases begin with the letters A or C. As we think of examples, conditions such as Addison's disease and Cushing's syndrome fall under adrenal cortex disorders. And to clarify for NCLEX accuracy, Graves' disease is not an adrenal disorder. As we move on to Addison's disease, we begin by noting that it is a rare condition. Continuing further, clients often have a hyperpigmented or tanned appearance. Then we emphasize that these patients cannot adapt to stress, which means they experience low blood pressure during stress and low glucose that increases the risk of shock. And to wrap up this slide, remember that the normal stress response is supposed to increase blood pressure and increase glucose. Next, when we discuss the treatment for Addison's disease, we start by recognizing that steroids, specifically glucocorticoids, are the primary therapy. As you continue to recall this, all steroids end in the suffix "-sone", and an easy memory aid here is that in Addison's, you add a "-sone". Finally, as we shift to Cushing's syndrome, remember the phrase "Cushy equals more", meaning excess secretion. For NCLEX preparation, you must know the signs of Cushing's syndrome. And to conclude, the symptoms include both classic Cushing's features along with typical steroid side effects. Here we begin by reviewing the physical features of Cushing's syndrome, and the first feature we notice is the moon face. As we continue, another key change that often appears is hirsutism. Moving forward, the next major feature is central obesity. After that, we also see gynecomastia, along with what is known as the buffalo hump. As we progress, we recognize that muscle atrophy in the extremities becomes very common. Next, there is sodium and water retention, which eventually leads to potassium loss. Continuing on, another classic feature is the presence of purple striae. Following this, many clients experience hyperglycemia. Then, we also observe easy bruising. As we near the end of this list, irritability becomes another notable characteristic. And finally, immunosuppression is a major physical effect of Cushing's syndrome. Now, let us walk through the essential nursing considerations for clients with Cushing's syndrome. And we begin with the fact that diabetics who are taking steroids will need more insulin. Next, we emphasize that steroids increase blood glucose even in clients who are not diabetic. Finally, when caring for a client with chronic obstructive pulmonary disease who is receiving Solumedrol, it is important to perform an AccuCheck every 6 hours. Now we shift into the treatment aspect, starting with adrenalectomy, which is the removal of the adrenal gland. As we move further, we clarify that bilateral removal of the adrenal glands causes Addison's disease. Continuing this explanation, we also note that bilateral removal requires lifelong steroids. Next in sequence, symptoms may resemble Cushing's again because of ongoing steroid therapy. Then we highlight that it takes 1 to 2 years to stabilize after surgery. And finally, endocrine surgery often creates the opposite disorder. Now we transition into childhood development and toy selection, beginning first with how to select age-appropriate toys. Next, we focus on the 3 key considerations. And the first consideration is safety. Then the second consideration is age appropriateness. Finally, the third consideration is feasibility. Now we look deeper into toy-related safety considerations. And we start with the guideline that no small toys should be given to children under 4, as this prevents aspiration risk. Moving to the next key point, no metal toys should be used when oxygen is in use, because of the risk of sparks and fire hazards. To clarify further, die-cast toys are considered metal. And lastly, we must beware of fomettes, because a fomite is a non-living object that carries microorganisms, and toys are common fomites in pediatric units. Let us begin by looking at the best and worst toys for infection risk, because this is a frequent NCLEX trap. The worst fomite is stuffed animals since they absorb germs and cannot be disinfected effectively. The best toy for infection control is hard plastic toys, because these can be disinfected easily and consistently, and the best choice for an immunosuppressed child is a hard plastic action figure, as it offers both safe play and the lowest infection risk. Now, let us move on to the feasibility principle, which simply asks, can the child realistically do this in this situation? When we consider swimming for a 13-year-old, we can say it is safe, yes. We can also say it is age-appropriate, yes, but it is not feasible in a body cast, and that is the key decision point. So always remember to use common sense when applying feasibility. Next, let us review age appropriateness, which is one of the most frequently tested topics on the NCLEX. When you are given an age, you must match the correct toy or activity. Developmental milestones always determine the correct play, and that is why this principle is so important. Now, let us talk about infants between age 0 to 6 months, who are in the sensory motor stage. The best toy for this stage is a musical mobile because it stimulates both sensory and motor development. If a mobile is not available, then you should choose large, soft toys, which still promote safe stimulation at this age. Finally, let us look at ages 6 to 9 months, when the child is developing object permanence. The best toys during this period are cover-uncover toys, such as jack-in-the-box toys, pop-up toys, and flapbooks. Activities like peekaboo and blanket pulls also support this developmental stage. The second best choice is large, hard toys, which remain safe and engaging. And the worst toy is a musical mobile because it becomes a strangulation risk once the child can pull up. As we move into the developmental stage of age 9 to 12 months, we first note that infants are developing vocalization, which means they are beginning to use their voice with more intention. This is why the best toys at this age are speaking and talking toys such as talking books or even Tickle Me Elmo. At this stage, they are also beginning purposeful activity with objects. And an easy example of this is simple block building. However, it is very important to remember that we do not choose toys requiring them to build, sort, stack, make, or construct. This is because children under 9 months cannot perform purposeful tasks, and selecting such toys would not match their developmental ability.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Now, as we shift into the toddler years, from 1 to 3 years old, the major focus is on gross motor development, which includes skills like running and jumping. Because of this, the best toys for toddlers are push-pull toys, such as a wagon, a lawnmower toy, or even a small stroller. We avoid giving toddlers toys that require fine finger dexterity, meaning no colored pencils and no scissors. Finger painting, however, is very appropriate because it uses gross motor movements rather than fine motor skills. And when we consider their social development, toddlers engage in what we call parallel play, meaning they play alongside other children without interacting directly. Moving forward into the preschool age, from 3 to 6 years, children are developing fine motor skills. So activities requiring finger dexterity become important at this stage. They are also developing balance, which makes toys like tricycles, tumbling activities, skating, and dance excellent choices. Swimming at this stage is considered gross motor and can actually be started even earlier. In terms of social play, preschoolers participate in cooperative play, meaning they begin playing together with shared goals. And this age group is highly imaginative, making pretend play a central and natural part of their daily activities. When we reach school-age children from 6 to 12 years, their development is defined by what we call the 3 C's. The first C is creative, meaning we should let them make things. And for this age group, blank paper is better than a coloring book, and a Lego creation is better than pre-made toys. The second C is collective, because they enjoy collecting items such as Pokemon cards, trading cards, or dolls. The third C is competitive, as they prefer games with winners, which is very different from preschoolers who typically prefer equal outcomes. Finally, when we discuss adolescence, the priority for this age group is peer group association. Because their social identity is strongly shaped by their friends, we should allow teens to gather unless someone in the group is fresh post-operative within 12 hours, or unless anyone is immunosuppressed, or unless anyone has a contagious disease. In these situations, gathering would not be appropriate or safe. Let us begin by understanding the basics. And first, I want you to remember that the lamina refers to the vertebral spinous processes, which are the bumpy bones you can actually feel along the spine. Then we have the term ectomy, which simply means removal. So, when we talk about a laminectomy, we are referring to a procedure that removes the posterior vertebral bone. The purpose of this surgery is to relieve nerve root compression by creating more space within the spinal canal. Because of this decompression effect, the procedure is also called decompression surgery. Now, as we shift into identifying what nerve root compression looks like, the first thing to recognize is pain. Following that, we look for paresthesia, which refers to numbness and tingling. The third hallmark sign is paresis, meaning muscle weakness. The location of these symptoms ultimately determines the overall presentation, the prognosis, and the appropriate treatment. And this is why location becomes absolutely critical in all neuro NCLEX questions. Moving on to the different laminectomy locations, we start with the cervical region, which refers to the neck, and this area innervates both the diaphragm for breathing and the arms. Then we look at the thoracic region, which is the upper back, and it innervates the abdominal muscles responsible for coughing as well as the gut that regulates bowel function. Finally, the lumbar region is in the lower back, and it innervates the bladder along with the legs. As we prepare for surgery, remember that changing the location changes the correct NCLEX answer. For a cervical laminectomy, the priority is breathing first, and if breathing is not listed, then the correct choice involves arm or hand function. For a thoracic laminectomy, the focus shifts to coughing and assessing bowel sounds. For a lumbar laminectomy, we prioritize bladder function such as voiding or checking for distension, or we focus on legs and feet function. Finally, when we enter the post-operative phase, the number one NCLEX answer for all spinal cases is to log roll the patient. We do not dangle these patients, meaning we do not allow them to sit at the edge of the bed before standing. Instead, they should move directly from lying to standing or walking. We also avoid sitting for more than 30 minutes. Although meals are acceptable since they are typically less than 30 minutes, the patient is allowed to walk, stand, and lie down without any restrictions. The only restriction applies to prolonged sitting. Let us begin by understanding that post-operative complications can be predicted simply by the location of the surgery. When the surgery is done in the cervical area, the major concern is pneumonia, because cervical involvement can impair breathing. Moving to the thoracic region, the complications expand to include pneumonia as well as ileus. When the surgery is performed in the lumbar area, the issues we watch for include urinary retention and leg problems. And the key NCLEX rule to always remember is that the location of the surgery predicts the complication. Now let us move into an important special surgical note. A typical laminectomy does not require chest tubes. However, an anterior thoracic approach may require chest tubes because the surgeon enters through the thorax. Next, let us talk about what it means when we say a laminectomy is done with fusion. The phrase "with fusion" means that a bone graft is taken from the iliac crest to stabilize the spine. Most laminectomies do not require fusion unless a disc is removed. When fusion is performed, there are two incisions. The first is the hip incision, which causes the most pain, produces the most bleeding or drainage, and is usually associated with a JP or hemovac drain. Because of that, the hip incision tends to cause the most post-operative issues. The second incision is the spine incision, and this is the one with the highest graft rejection risk. Both incisions, however, have an equal risk for infection. Cadaver bone grafts are often used because they reduce the need for a hip incision. As we continue, let us review the temporary activity restrictions for the patient during the first 6 weeks. Patients should not sit for more than 30 minutes. They must lie flat and log roll for safety. They should not drive. They should avoid lifting anything heavier than 5 pounds. And here is an NCLEX hint to hold on to. When you are unsure, 6 weeks is usually the correct answer for temporary restrictions. Finally, let us go over the permanent restrictions that are essential for long-term spinal safety. Patients should never lift objects by bending at the waist and must always lift using their knees. For anyone who has had a cervical laminectomy, they must never lift anything overhead for the rest of their life. Patients should permanently avoid jerky rides, off-roading, or horseback riding. And the key NCLEX concept to keep in mind is that spinal safety always depends on the location of the surgery. As we begin, I want to remind you that laminectomy principles apply to many spinal cord questions, so keeping them in mind will give you a major advantage on NCLEX. And to use those principles correctly, you must always identify the location first, because that determines the symptoms, the complications, and ultimately your priorities. Now, moving into lab values, remember that you must know the normal values and which abnormalities are the most dangerous. NCLEX is not simply testing memorization here. It is testing priority-based interpretation. And that is why we use the priority scheme, where A is low priority with no action needed, B means monitor because there is concern but no immediate action required, C is critical and means you must act by holding, assessing, preparing, or calling, and D represents deadly values, which require a stat emergency response where you cannot leave the bedside. Before moving to the next topic, here's some great news for you. If you're feeling confused about what to study, or how to prepare effectively for the NCLEX, you're not alone. To support serious NCLEX aspirants, we're providing 30 days of completely free NCLEX study content on WhatsApp, which includes high-yield PDF notes, exam-focused concepts, daily practice questions, and clear, structured guidance. There is no payment required and no commitment involved. This is 100% free study support designed to help you prepare the right way. Simply click the WhatsApp link given in the video description and the channel bio. Send, "Hello, I want to join the 30-day free NCLEX study content program." Our team will share NCLEX study content with you regularly for the next 30 days. Now, let's move on to the next topic. When it comes to pH, the normal range is 7.35 to 7.45. And the priority here is that a pH in the 6s is automatically a level D. In that situation, you immediately assess vital signs, you treat the underlying cause as directed by the provider, and you call the provider immediately, because this is the fastest call of all lab values. For BUN, the normal level is 8 to 25, and the priority is that an elevated BUN is considered an A, which means low priority, so your job is simply to assess for dehydration, which is a very common NCLEX clue. With hemoglobin, the normal range is 12 to 18. A value between 8 and 11 places the patient at a B priority, meaning you assess for bleeding or malnutrition. But when hemoglobin drops below 8, that becomes a C priority, so you assess for bleeding, you prepare for a transfusion, and you call the provider. Let us begin by looking at bicarbonate, where the normal range is 22 to 26. When we talk about priority for bicarbonate, A indicates abnormal, which means it is not a priority. Now moving on to carbon dioxide as an arterial blood gas value. Remembering that this does not apply to chronic obstructive pulmonary disease clients, the normal range is 35 to 45. When we think about priority, C represents a high carbon dioxide level in the 50s. So we first assess respiratory status, and then coach pursed lip breathing. If the carbon dioxide reaches the 60s, this represents respiratory failure and falls under priority D, so we assess respirations, prepare for intubation and ventilation, and call respiratory therapy followed by the provider. Next, let us look at hematocrit, where the normal range is 36 to 54, which is approximately 3 times the hemoglobin. For priority, B indicates that an elevated hematocrit requires us to assess for dehydration. Now we will review partial pressure of oxygen as an arterial blood gas, where the normal range is 78 to 100. For priority, C applies when the partial pressure of oxygen is in the 70s, meaning we assess respiratory status and prepare to give oxygen. Priority D applies when the partial pressure of oxygen is in the 60s, which signals respiratory failure, so we prepare for intubation and ventilation and call respiratory therapy followed by the provider. It is important to note that hypoxia initially causes an increased heart rate. Finally, let us talk about oxygen saturation, where the normal range is 93 to 100. When we look at priority, C applies when the saturation is below 93, so we assess and give oxygen as needed. We also include a pediatric caution that values below 95% are concerning. And we must remember that false elevation can occur with anemia or after recent dye procedures. Here, let us begin by reviewing our priority definitions. First, C means must act, which follows the sequence of hold, assess, prepare, and call. Next, D means deadly, which requires immediate stat action and instructs us not to leave the bedside. Then we remember that we always assess before acting unless delaying the action increases the client's risk. And finally, the type of question, whether it is a first question or a best question, affects how we determine the priority sequence. Now let us talk about creatinine. The normal range is 0.6 to 1.2. When it comes to priority, A is assigned when creatinine is elevated. This indicates chronic kidney disease and is not emergent. You call the provider only if a dye test is scheduled, and even then, it is considered non-urgent. Moving on, let us look at INR related to Coumadin monitoring. The normal range is 2 to 3. For priority, C is assigned when the INR is 4 and above. In this case, you hold Coumadin. Then you assess for bleeding. After that, you prepare vitamin K, and finally, you call the provider. Next, we will focus on potassium. The normal range is 3.5 to 5.3. For priority, C is assigned when potassium is less than 3.5. In that scenario, you assess the heart, then you prepare potassium replacement. And next, you call the provider. The next priority level is also C when potassium is between 5.4 and 5.9. In this case, you hold potassium. Then you assess the heart. After that, you prepare D5W with insulin and kayexalate. And once again, you call the provider. The highest priority is D when potassium is greater than 6. You follow the same interventions, but this time they must be done stat and multiple staff members are needed. Finally, let us review BNP, which is a major indicator of heart failure. The normal level is less than 100. For priority, B is assigned when BNP is elevated. This indicates chronic congestive heart failure. And in this situation, we monitor for worsening symptoms. As we begin with sodium, or NA, remember that the normal range is 135 to 145. When we look at priority, we start with B, which means that an abnormal value requires you to assess. When sodium is high, you assess for dehydration. When sodium is low, you assess for fluid overload. Then we move to C, which means an abnormal sodium level with a change in level of consciousness becomes a higher priority. Now moving on to white blood cells, absolute neutrophil count, and CD4 levels. We begin with the ranges. The white blood cell count should be between 5,000 and 11,000. The absolute neutrophil count should be greater than 500. The CD4 count should be greater than 200. When we talk about priority, we focus on C, which is when these values fall below their thresholds. When that happens, you assess for infection. You then initiate neutropenic precautions. And you remember that a CD4 count below 200 indicates AIDS. Next, looking at platelets, their normal range is 150,000 to 400,000. For priority, we again focus on C because a platelet count below 90,000 requires bleeding precautions. Then we look at D because a platelet count below 40,000 indicates a high risk for spontaneous bleeding. Continuing with red blood cells, the normal range is 4 to 6 million. For priority, we use B, which means that an abnormal red blood cell value should be monitored. Finally, we come to the 5 deadly D lab values, which represent the absolute highest priority. These include a pH in the 6s, potassium greater than 6, carbon dioxide in the 60s, oxygen partial pressure in the 60s, and platelets below 40,000. And remember that the NCLEX rarely compares these against each other. As we begin this slide, we focus on learning your C-level critical labs. And we start by understanding that you must practice identifying all C-level values to determine when to hold, when to assess, when to prepare, and when to call. Each of these actions follows directly from recognizing that a C-level lab is dangerous, so we simply move through the sequence of hold, assess, prepare, and call in order to respond safely and correctly on the NCLEX. Now on this slide, we shift into the key principles of psychotropic drugs, and we begin by recognizing that classes overlap and many effects are similar. As we continue, we emphasize that all psych drugs cause low blood pressure and weight changes, and this usually means weight gain, although a few may cause weight loss. Moving forward, we remember that the therapeutic effect takes 2 to 4 weeks, and this is why we teach patients not to stop early, because 1 week is too soon to judge effectiveness. On this slide, we turn our attention to phenothiazines, which are typical antipsychotics, and we start by noting that they are first-generation antipsychotics. We continue by pointing out that all of them end in -zine. Next, we explain that they do not cure, but instead reduce symptoms. As we move along, we add that large doses act as antipsychotics, which is why we say zines for the zany. We also explain that small doses serve as antiemetics. Finally, we wrap up by reinforcing that major tranquilizers are considered the big guns for severe symptoms. Here, we walk through the major side effects of phenothiazines, remembered by the pattern A, B, C, D, E, F plus AG, and we go in order. A stands for anticholinergic effects such as dry mouth. B stands for blurred vision. C stands for constipation. D stands for drowsiness. E stands for extrapyramidal symptoms, which appear Parkinson-like. F stands for photosensitivity. And finally, a G reminds us of a granulocytosis, meaning low white blood cell count and an increased infection risk. As we move to the final slide, we clarify how to respond to side effects versus toxic effects. We begin by stating that for a side effect, you teach the patient, inform the provider, and continue the medication. In contrast, when there is a toxic effect, you hold the dose and call the provider immediately. And lastly, we highlight that the priority nursing diagnosis in these situations is risk for injury due to sedation or extrapyramidal symptoms. Let us begin by talking about phenothiazine decanoate, which is a long-acting intramuscular form. It is commonly used for non-compliant patients. It may even be court-ordered in some situations. Now, moving forward, let us look at tricyclic antidepressants, which are older antidepressants belonging to the NSSRI class. They act as mood elevators and are often referred to as happy pills. Some examples include Elavil, Tofranil, Aventel, and Deseril. Next, we will go over the side effects of tricyclic antidepressants, where A stands for anticholinergic, B stands for blurred vision, C stands for constipation, D stands for drowsiness, and E stands for euphoria. Now let us shift to benzodiazepines, also known as minor tranquilizers, which are anti-anxiety medications. All of them contain the ZEP sound in their names. Common examples include diazepam, lorazepam, clonazepam, and Xanax. Their uses include preoperative anesthesia, muscle relaxation, alcohol withdrawal, seizure control, and reducing ventilator agitation. They are fast-acting, but are recommended only for 2 to 4 weeks. Finally, let us compare benzodiazepines with antidepressants, where the minor tranquilizer works immediately and is used short-term. The antidepressant takes 2 to 4 weeks to work and is used long-term. They are often started together until the antidepressant becomes effective. The best way to understand this is through the analogy that heparin is to warfarin as a tranquilizer is to an antidepressant. As we begin discussing benzodiazepines, the first thing I want you to remember is that the side effects can easily be recalled using the letters A, B, C, and D. A stands for anticholinergic effects, which is an important baseline concept for NCLEX level awareness. B represents blurred vision, which is a common and very testable effect of these medications. C refers to constipation, which continues the standard pattern seen in many sedating medications. D means drowsiness, a hallmark effect that directly impacts client safety. And because of these effects, the priority nursing diagnosis is a risk for injury, which is exactly what the NCLEX expects you to identify. As we move into monoamine oxidase inhibitors, remember that these are early antidepressants and are rarely used now. You can easily recognize them by the rhyme Marplen, Nardil, and Parnate, which helps tremendously on the exam. Their side effects follow the same A, B, C, D pattern, giving them a standard antidepressant profile. Now, let us shift into the most critical patient teaching for monoamine oxidase inhibitors, especially when it comes to preventing a hypertensive crisis. To prevent a hypertensive crisis, clients must avoid tyramine-containing foods. They must avoid aged cheese, although mozzarella and cottage cheese are allowed. They must also avoid yogurt for safety. Cured, preserved, and organ meats must be avoided as well. They must stay away from alcohol and caffeine to reduce risk. Chocolate must also be avoided. Fermented foods must be excluded from the diet. Bananas, avocados, and dried fruits are also on the avoid list. And finally, clients must avoid all over-the-counter medications unless prescribed, which is a strict NCLEX warning. Next, let us look at lithium, which is used to treat bipolar disorder and works by reducing mania. Lithium has a unique mechanism because it stabilizes nerve cell membranes. Its side effects resemble electrolyte disturbances and are easy to remember. The first P stands for peeing, the second P stands for pooping, and the third P stands for paresthesia, which is the earliest electrolyte sign. Finally, when we talk about lithium toxicity, the first action is to hold the medication and notify the provider. The signs include tremors, which are often one of the earliest red flags. A metallic taste can appear, signaling rising levels, and severe diarrhea is another critical indicator of toxicity. Let us begin by looking at the key nursing considerations for lithium, and the first point is to increase fluids because this prevents dehydration. Moving forward, we also need to monitor sodium levels. Now, if the client is sweating heavily, we give electrolyte fluids and not plain water. Next, remember that normal sodium is required for lithium to work. This means that low sodium leads to lithium toxicity. And finally, high sodium makes lithium ineffective. Now let us shift our attention to Prozac, which is an SSRI, and the first thing to know is that it is similar to Elavil. As we continue, we note that the side effects follow the pattern A, B, C, D, E. Another important point is that it causes insomnia, so we give it before noon. And lastly, for young adults and adolescents, we must monitor for increased suicidal risk after a dose change. Next, let us move to Haldol, a typical antipsychotic, and we begin by noting that it has a decanoate intramuscular form. Continuing on, its side effects include A, B, C, D, E, F plus AG. What carries the highest NCLEX risk is neuroleptic malignant syndrome, or NMS. And we end this slide by recognizing that elderly and young white schizophrenics are at the highest risk. As we go deeper, we now focus on neuroleptic malignant syndrome, beginning with the fact that it is a medical emergency. It presents with a very high fever, over 105 degrees Fahrenheit. Then we compare by saying that EPS is a side effect, whereas NMS is life-threatening. The first action is to check the temperature. And if the temperature is greater than 102 degrees Fahrenheit, we call emergency response. Finally, we wrap up with Haldol safety, and the key point is that sedation and EPS increase fall and injury risk. And to finish, we remember that patients often become weak quickly after dosing. Let us begin with clozapine, also known as Clozaril. It is the prototype second-generation antipsychotic, and it is specifically used for severe schizophrenia. One major advantage is that it has very minimal A, B, C, D, E, F effects, which makes it safer in those categories compared to other antipsychotics. However, the major risk with clozapine is a granulocytosis, often abbreviated as a G, which leads to a severe infection risk. Because of that, the nursing priority is to monitor the white blood cell count regularly. Now moving on to ziprasidone, also known as Diodon. This medication carries a black box warning. It prolongs the QT interval, which increases the risk of sudden cardiac arrest. For this reason, we must avoid it in patients who have cardiac disease. And an easy memory tip is that many medications in this class end in zapine. Next, let us talk about sertraline, commonly known as Zoloft. It is an SSRI, and although it may cause insomnia, it can still be given at bedtime if needed. The major NCLEX focus for this medication is its drug interactions. So let us look at the drug interactions associated with Zoloft. First, cytochrome P450 inhibition increases the toxicity of other drugs, which often requires lowering their doses. Second, combining Zoloft with St. John's wort can cause serotonin syndrome, and the symptoms include being sweaty, apprehensive, dizzy, and having a headache, which can be remembered with the phrase SAD head. Third, there is a warfarin interaction, which increases the bleeding risk and may require lowering the warfarin dose. Before moving to the next topic, here's some great news for you. If you're feeling confused about what to study, or how to prepare effectively for the NCLEX, you're not alone. To support serious NCLEX aspirants, we're providing 30 days of completely free NCLEX study content on WhatsApp, which includes high-yield PDF notes, exam-focused concepts, daily practice questions, and clear, structured guidance. There is no payment required and no commitment involved. This is 100% free study support designed to help you prepare the right way. Simply click the WhatsApp link given in the video description and the channel bio. Send, "Hello, I want to join the 30-day free NCLEX study content program." Our team will share NCLEX study content with you regularly for the next 30 days. Now, let's move on to the next topic. Finally, let us go over pregnancy due date calculation. We use Nagel's rule. You start with the first day of the last menstrual period. Then you add 7 days and subtract 3 months. For example, if the last menstrual period was June 10th, the due date is approximately March 17th. Let us begin with an overview of pregnancy weight gain. And to start with, the total weight gain is 28 pounds plus or minus 3. Moving forward, in the first trimester, the expected pattern is 1 pound per month, which is approximately 3 pounds in total. As we continue, the second and third trimesters follow a different pace, where the weight gain should be 1 pound per week. Finally, to predict weight gain at any point, we use the simple formula of the week minus 9 equals the expected gain. Now, as we shift into interpreting weight gain, we begin by recognizing that an acceptable variation is plus or minus 1 to 2 pounds. When the weight differs by 3 pounds or more, we need to assess the client further. If the variation reaches 4 pounds or more, this may indicate a possible complication. And when the client is underweight by 6 pounds or more, we should consider performing a biophysical profile. Next, let us explore the basics of fundal height, beginning with the fact that the fundus is not palpable until 12 weeks. As the pregnancy progresses, the fundus reaches the level of the umbilicus at 20 to 22 weeks. This measurement helps determine the trimester and provides key fetal viability indicators. As we continue, let us connect fundal height with nursing priority. In the first trimester, when the fundus is not yet palpable, the mother remains the priority. When the fundus is at or below the level of the umbilicus. In the second trimester, the mother is still the priority. However, when the fundus rises above the umbilicus in the third trimester, the fetus becomes the priority. Lastly, let us review the positive signs of pregnancy. And we begin by noting that there are only 4 true positive signs. The first is the appearance of the fetal skeleton on an X-ray. The second is the visualization of fetal presence on an ultrasound. The third is the fetal heart rate being heard between 8 and 12 weeks. The fourth is when the examiner palpates actual fetal movement. And importantly, there are no false positives for these signs. Let us begin with understanding OB question strategy. And the first thing to remember is that facts have ranges, so you must read very carefully. Now, as we look closer, you will see that there are 3 question types. The first type is asking for the earliest in the range. The second type is asking for the most likely, which is the midpoint. And the third type is asking what should be achieved by the end of the range. For example, quickening follows the same pattern, where the first is around 16 weeks. The most likely is 18 weeks. And the should by point is 20 weeks. Moving ahead, let us talk about probable and presumptive signs. And the key idea here is that all urine and blood tests are not positive signs. As we continue, Chadwick's sign refers to a cyanotic cervix, vagina, and labia. Then we have Goodell's sign, which means cervical softening. After that comes Hegar's sign, which means uterine softening. And an easy way to remember these is that they occur in alphabetical order. Now, let us look at the pregnancy visit schedule. And to start, until 28 weeks, the client should be seen monthly. From 28 to 36 weeks, the schedule changes to every 2 weeks. Then from 36 to 42 weeks, visits become weekly. And finally, remember that induction or a C-section should happen by week 42. Next, let us break down hemoglobin changes in pregnancy, beginning with the fact that the normal female range is 12 to 16. Now moving into pregnancy-specific values, acceptable levels in the first trimester are 11. In the second trimester, acceptable levels are 10.5. In the third trimester, acceptable levels are 10. And overall, the acceptable minimum is 9. Finally, let us go over common pregnancy discomforts, starting with the reminder that morning sickness is best managed by taking dry carbohydrates before rising. Urinary incontinence occurs in the first and third trimester, so the client should void every 2 hours. Breathing difficulty is common in the second and third trimester and can be relieved by using the tripod position. And back pain is best managed with pelvic tilt exercises. When we begin discussing labor, the most valid sign of true labor is always regular, progressive contractions. And this is the key indicator that labor is actually happening. It is also important to understand that a bloody show or rupture of membranes alone does not equal labor, because these can occur without true cervical change or active labor progression. As we move into cervical changes in station, dilation progresses from 0 to 10 centimeters, and this measurement tells us how open the cervix is becoming. Effacement changes from thick to 100%, showing us how thin the cervix has become. Station refers to the relation of the presenting part to the ischial spines, and this helps us understand how far the baby has descended. A negative station means the baby is above the ischial spines, which is not yet favorable, while a positive station means the baby is below the spines, which is a good sign of progress. Engagement is identified at 0 station, meaning the presenting part is exactly at the ischial spines. Now, when we look at fetal lie and presentation, a longitudinal lie is considered normal and is what we expect in labor. A transverse lie is an emergency because the baby is positioned sideways. An oblique lie is a malposition and also not ideal for delivery. The most common fetal presentations are right occiput anterior, or ROA, and left occiput anterior, or LOA. Next, we review the stages and phases of labor, where stage 1 represents the labor process and includes 3 phases. The latent phase ranges from 0 to 4 centimeters. The active phase progresses from 5 to 7 centimeters, and the transition phase moves from 8 to 10 centimeters. Contraction norms include a duration of less than 90 seconds and a frequency that is more than 2 minutes apart. Finally, when we focus on the purpose of contractions, during stage 1, the contractions work to dilate and efface the cervix. During stage 2, the contractions help deliver the baby. During stage 3, the contractions help deliver the placenta. And during stage 4, the contractions work to stop bleeding by maintaining strong uterine tone. As we begin, let us look at the stages versus the phases and identify the priorities clearly. The second phase priority is pain management. And this means our main focus during the second phase is keeping the birthing client as comfortable and supported as possible. Next, the second stage priority is airway clearance, because once the baby is crowning and delivery is imminent, ensuring a patent airway becomes the most urgent concern. Moving forward, the third phase actions are to check dilation and assist breathing, which helps us guide the client safely through the progression of labor. Finally, the third stage actions are to assess blood loss and ensure an intact placenta, because these steps confirm maternal stability after the baby is born. Now, let us shift into understanding contraction timing in a simple NCLEX-focused way. When we measure frequency, it is always from beginning to beginning of each contraction, and this is essential for determining how often contractions occur. When we consider duration, it is measured from the beginning to the end of the same contraction, and this tells us how long each contraction lasts. When it comes to intensity, it is subjective, and we palpate the fundus with our fingertips to determine how strong the contraction feels. Next, let us talk about painful back labor, which is something you will often see in the clinical setting. It usually occurs with an occiput posterior position, and you can remember this easily by thinking, "oh, pain." It is considered a low priority because it is uncomfortable, but not typically dangerous for the fetus. For interventions, the first step is positioning the client in the knee-chest position to help rotate the fetus. Then we push with counter-pressure to the sacrum, which helps relieve that intense back pain. Now we come to a true obstetric emergency, which is a prolapsed cord. In this scenario, the cord becomes compressed, leading to a significant fetal hypoxia risk, and this requires immediate intervention. The first step is to push the head off the cord to relieve pressure and restore blood flow. Then we position the client in the knee-chest position to further reduce compression. Finally, we prepare for an emergency cesarean section, because this is the definitive management to save the fetus. To finish this section, let us review the Lion protocol, which is used for all other complications. The first step is to turn the client to the left side, promoting optimal perfusion. The next step is to increase the intravenous infusion to support circulation. Then we provide oxygen to improve fetal and maternal oxygenation. After that, we notify the provider so further intervention can occur. And if the client is on Pitocin, we stop it first before doing anything else. Let us begin by reviewing pain medications in labor. Do not give pain medication if birth is likely during the peak of the drug's effect. A Primi Gravida at 5 centimeters is considered safe for intravenous medication. A Multigravida at 8 centimeters should avoid intramuscular medication because she is likely to deliver soon. Now, moving into fetal monitoring patterns, there are 7 patterns you must know. These are high-yield, easy-to-remember NCLEX essentials. Next, let us look at low fetal heart rate. And fetal heart rate under 110 is concerning. This is bad, so initiate LION. If an oxytocin infusion is running, stop it. Now shifting to high fetal heart rate, and fetal heart rate over 160 is the threshold. This is not considered a high-priority issue. Your action is to document the findings. Then check the maternal temperature because maternal fever can elevate the fetal heart rate. Finally, let us go over low baseline variability. This occurs when the fetal heart rate remains unchanged, creating a flat line pattern. This is bad, so initiate LION. It indicates possible fetal hypoxia. Here is what we mean when we talk about high baseline variability. Fetal heart rate is constantly fluctuating, and that is exactly what we want to see. This is good, so simply document it. It indicates adequate fetal oxygenation. Now let us move into a simple stability rule reminder that helps guide fetal monitoring interpretation. After birth, stable vital signs are considered good. Before birth, stable or non-changing fetal heart rate is considered bad. Opposites matter in fetal monitoring. Next, let us look at late decelerations. The heart rate slows near the end or after a contraction. This is bad, so initiate the LION interventions. It suggests uteroplacental insufficiency. Now let us shift to early decelerations. The heart rate slows before or at the start of a contraction. This is normal, so just document it. It indicates head compression. Finally, let us talk about variable decelerations. These are abrupt variable drops in the heart rate. This is very bad and is often associated with cord prolapse. Immediate actions include push and position. So let us begin with the summary pattern rules, where we remember that there are 3 good and 3 bad. And all of these start with the letter L, which is why we use the word lion. Then we have 1 variable, which reminds us to think about push and position. Now moving into the VEALCHOP mnemonic, we start by understanding that V stands for variable, which means cord compression. Then E stands for early decelerations, which indicate head compression. After that, A represents acceleration, which reassures us that everything is okay. And finally, L stands for late decelerations, which point to placental insufficiency. Next, as we reach the NCLEX tiebreaker rule, remember that in obstetrics, you always check the fetal heart rate first. Moving on to stage 2 of labor, which is the baby delivery stage, we follow the correct order by first delivering the head. Then we suction the mouth and then the nose. After that, we check for a nuchal cord, and once that is done, we deliver the shoulders and the body. Finally, we make sure to apply the newborn identification band before leaving the delivery area. And now we arrive at stage 3 of labor, which is the placenta delivery stage, where we ensure that the placenta is intact. We also confirm the 3-vessel cord, which includes 2 arteries and 1 vein. As we move into the stage 4 period of labor, remember, this is the recovery phase that includes the first 2 hours after placenta delivery. During this time, we perform 4 tasks, 4 times per hour, which means every 15 minutes we repeat the same essential checks to ensure maternal stability. When we begin our stage 4 assessments, the first step is to monitor vital signs. Here we are watching closely for shock, which shows up as blood pressure going down, heart rate going up, and the client appearing pale, cold, and clammy. Next, we move to the fundus check. And if the fundus feels boggy, we massage it, and if the fundus is displaced, then we catheterize to correct bladder-related displacement. Continuing with stage 4 assessments, we now examine the perineal pads to assess bleeding. Because excessive bleeding is defined as a pad becoming fully saturated within 15 minutes. After that, we roll the patient to check for hidden bleeding and inspect the perineal area carefully for any signs of concealed hemorrhage. As we shift into postpartum assessments, remember that these checks are usually done every 4 to 8 hours depending on the client's stability. To guide our assessment systematically, we follow the BUBBLEHEAD framework. To break down the bubblehead details, we begin with B for breasts. Then we move to U for the uterine fundus, which should be firm, midline, and descending 1 centimeter per day. The next B stands for bladder, followed by another B for bowel. And finally, we assess L for lochia, which progresses from rubra to serosa to alba. As we continue with our postpartum bubblehead assessment, we move next to the letter E, which stands for episiotomy. After that, we look at H, which refers to hemoglobin and hematocrit. Then we come to the next E, which focuses on the extremities. Here, we assess for thrombophlebitis. And when we are checking for this, bilateral calf circumference is more reliable than Hohmann's sign. As we move forward with the remaining components of bubblehead, the next letter is A, which stands for affect. Following that, we review D, which represents discomforts. And the NCLEX focus here continues to emphasize the uterine fundus, the lochia, and the extremities. Now, let us turn to a few medication helps and hints, which are simply meant to help you remember basic medication facts. Humulin 7030 is a mix of NPH insulin and regular insulin. It is used for scheduled glucose control. And along with that, it is important to know basic newborn variations and normal findings. Next, let us go through the newborn variations you need to recognize. Caput succedaneum crosses suture lines, and it is symmetrical. Cephalohematoma involves subperiosteal bleeding, and it does not cross sutures. Physiologic jaundice appears after 24 hours, and pathologic jaundice is present at birth or within 24 hours. Finally, let us wrap up with a quick obstetric medications overview. You need to know the general purpose and the key NCLEX relevant effects. There are 6 major medication groups, and throughout all of them, your focus should stay on safety, maternal changes, and fetal impact. Let us begin with tocolytics, which are medications used with the purpose to stop labor in threatened preterm birth. Now, when we talk about terbutaline, it is important to remember that it causes maternal tachycardia. Moving on to magnesium sulfate, we need to monitor for toxicity. It causes hypermagnesemia, where everything decreases. This means the heart rate decreases, the blood pressure decreases, the reflexes decrease, and we want to keep them at +2. The respiratory rate decreases, and the minimum acceptable is 12, and the level of consciousness decreases. NCLEX prioritizes reflexes and respiratory rate. Therefore, we monitor reflexes and respirations closely. Now let us shift to oxytocics, which have the purpose to stimulate, start, or strengthen labor. When we consider Pitocin, also known as oxytocin, the primary risk is uterine hyperstimulation. This includes contractions lasting more than 90 seconds or contractions occurring less than 2 minutes apart, and both are dangerous for fetal oxygenation. Next is methazine, which causes increased blood pressure due to vasoconstriction. For this reason, we avoid it in hypertensive clients. As we continue, let us look at fetal lung maturation medications. Betamethasone, which is a steroid, is given to the mother. It is administered as an intramuscular injection. It is given before birth. It can be repeated while the fetus remains in utero. Survanta, which is a surfactant, is given to the newborn. It is given by transtracheal administration, and it is given after birth. Now, moving into insulin basics, Humulin 7030 is a mix of 70% NPH and 30% regular. When mixing insulins, yes, insulins can be mixed. We draw up clear to cloudy, meaning regular to NPH. We pressurize the NPH first and then the regular. We draw up the regular first and then the NPH. And the memory aid to help you recall this is that RN draws up RN. Finally, when selecting injection needles, intramuscular injections require you to look for answers containing ones, such as a 21 gauge. Subcutaneous injections require you to look for answers containing 5s, such as a 25 gauge. As we begin comparing heparin with Coumadin, also known as warfarin, let us start with the route of administration. Heparin is given either intravenously or subcutaneously, while Coumadin is given orally only. Moving into onset, heparin has an immediate onset of action, whereas Coumadin takes several days to a week to show full effect. Now looking at duration, heparin should not be used for more than 3 weeks, except for Lovenox, because prolonged use can lead to antibody formation. And in contrast, Coumadin is suitable for long-term therapy, and lifelong use is even possible. Continuing with our comparison, let us talk about antidotes. Heparin is reversed with protamine sulfate, while Coumadin is reversed with vitamin K. When it comes to monitoring tests, heparin is monitored using the PTT, and Coumadin is monitored using the PT or INR. Regarding pregnancy safety, heparin is considered safe to use during pregnancy, whereas Coumadin is not safe in pregnancy. And as a special note here, the only major antipsychotic considered safe in pregnancy is Haldol. Now, as we shift to diuretics, remember that any diuretic ending in the letters X wastes potassium. Diuril also wastes potassium. All of the remaining diuretics are potassium-sparing. And NCLEX often tests whether potassium increases or decreases, so keeping this distinction clear is essential. Next, when we discuss a baclofen, it is tested as a class of muscle relaxants. A great memory aid is baclofen, which helps you recall baclofen. The side effects include fatigue and drowsiness, as well as muscle weakness. For teaching points, clients should avoid alcohol, they should not drive, and they should not operate heavy machinery. And another muscle relaxant that is commonly tested is Flexeril. Finally, when we review pediatric teaching and cognitive development, remember, this is a review of cognitive development concepts, and NCLEX may not name Piaget directly. The questions typically focus on how to teach children based on their developmental stage, and the teaching method must always match the child's cognitive abilities to ensure safe and effective learning. As we begin, let us walk through Piaget's 4 stages of cognitive development, starting with 0 to 2 years, which is known as the sensory-motor stage. Then we move into 3 to 6 years, which is called the pre-operational stage. After that comes 7 to 11 years, which is the concrete operational stage. And finally, we look at 12 to 15 years, known as the formal operational stage. The key NCLEX focus here is to always match your teaching strategy to the developmental level of the child. Now, let us explore the sensory-motor stage from 0 to 2 years, where the child is present-oriented and has no concept of past or future. During this period, they are only aware of what is happening right now. That is why the teaching method is to teach while doing, and everything must be in the present tense. Verbal teaching alone is used because they cannot learn from play yet. And since infants cannot understand preparation or follow-up, there is no effective pre-operative or post-operative teaching, meaning all teaching is directed to the parents only. To understand this better, teach during the procedure, not before. You should explain your actions as they occur, such as saying, "I am listening to your chest now." At this age, do not expect retention or reasoning because their cognitive ability does not support it. And an important NCLEX micro note is that anticipatory guidance is always directed to the parents, not to the infant. Moving ahead, the pre-operational stage from 3 to 6 years is fantasy-oriented, imaginative, and often illogical. Children at this stage cannot be reasoned with consistently. They understand past and future, but only in short time frames. Therefore, we teach shortly before or after an activity, ideally on the same day. The best teaching method uses future tense along with play-based learning. To apply this in practice, use dolls, equipment, and play to explain procedures. Provide simple explanations for what you are going to do. Avoid giving too much time because their imagination may increase anxiety. And finally, use familiar objects to help reduce fear and make the experience less intimidating.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
As we move into the concrete operational stage, which includes children 7 to 11 years old, it is important to remember that they are very rule-oriented. They think logically, but only in concrete terms. At this stage, they do not have the ability for abstract thinking yet. These children also prefer one correct way to do things. You may even notice that they will correct you if something you do is different from what a previous caregiver taught them. That is why the teaching method for this age group requires you to teach days ahead and demonstrate skills clearly. When we think about how to teach children in the concrete operational stage, we use reading materials and clear demonstrations. We also allow them to practice skills step by step. It is important to explain procedures in concrete, literal terms. And here is the NCLEX micronote to remember. Children in this stage perform their own care skills, but they do not manage care decisions. Now transitioning into the formal operational stage, which covers ages 12 to 15, These learners can think abstractly and understand cause and effect. Teaching at this point becomes adult style and is no longer considered pediatric. They can participate in decisions and understand the rationale behind what you teach. This is also the first age capable of managing their own care, which begins at 12 years. Although skill performance can occur at younger ages, care management requires abstract reasoning. To clarify NCLEX expectations about management versus skills, remember that managing care begins at 12 years and involves decision-making, planning, and self-responsibility. Children ages 7 to 11 can perform care skills but cannot manage care. Also, severity of illness does not determine independence. Age does. For example, a 10-year-old with a minor injury cannot manage care, whereas a 13-year-old with a chronic illness can manage care. As we begin the principles of psychiatric nursing, keep in mind that there are 7 core principles essential for safe therapeutic communication. These principles are critical for answering NCLEX psychiatric questions correctly. As we begin with Principle 1, we need to know the phases of the therapeutic relationship. First, we start by identifying which phase we are in, whether that is the pre-interaction phase, the introduction or orientation phase, the working phase, or the termination phase. And as we continue, we remember that our actions must match the phase because the NCLEX often tests sequencing. As we move into Principle 2, we focus on gift giving. In psychiatric settings, we do not give or receive gifts. This is because we must avoid misinterpretation of meaning. For example, we do not accept flowers from a client with schizophrenia, as they may be perceived as symbolic or even as a proposal. And finally, the NCLEX tip here is that declining a gift maintains professional boundaries. Now transitioning to Principle 3, we emphasize not giving advice. We need to avoid directing the client's decisions. So if a client asks, "What should I do?" we respond by saying, "What do you think you should do?" It is important to remember that advice is allowed in medical, surgical, or pediatric settings, but not in psychiatric care. And the NCLEX focus here is to promote client autonomy. Moving forward to Principle 4, we discuss why we do not give guarantees. We never promise outcomes. Statements like, "You will be fine" or "Everything will work out" are unsafe. And on the NCLEX, guarantees count as false reassurance, which blocks communication. And now, with Principle 5, we concentrate on the concept of immediacy. The best response keeps the client talking right now. We must avoid answers that prematurely end discussion, such as saying, "Refer to social work," when the client is actively expressing feelings. And the high-yield rule here is that it is almost never wrong to encourage verbalization. As we move into Principle 6, we focus on the idea of concreteness. This means we should use clear, direct, literal communication. It is important to remember not to use slang or figurative language. Clients may interpret statements literally, which can easily lead to confusion. For this reason, we also must avoid using or reinforcing neologisms. Now let us explore Principle 7, which is empathy, and this is truly the core of Psych NCLEX. Empathy means we communicate acceptance of the client's feelings. It is essential that we validate feelings as real, valid, and worthy of attention. At the same time, we must avoid non-therapeutic responses such as saying, "Do not worry," saying "You should not feel something," saying "I would feel something," or saying "Most people would do something." Next, let us look at how to identify empathy questions on the NCLEX. These questions always contain a client quote. All of the answer choices contain nurse responses. Your task is to choose the statement that matches the client's feeling, not their words. To select the empathy response, start by putting yourself in the client's place. Then read and interpret the underlying emotion in the scenario. Ask yourself, "If I said these words and meant them, how would I be feeling?" Finally, choose the answer that reflects that feeling, or at least comes closest to it. As we wrap up this concept, remember to avoid the NCLEX sucker answer. This means do not choose responses that overemphasize the client's words. Also avoid responses that ignore the underlying feeling. The NCLEX distractor often repeats the client's statement instead of validating the emotion. The correct choice is the one that reflects what they felt, not what they said. Let us begin by understanding that prioritization tests how you rank 4 different clients. And this means you must carefully determine who is the sickest or the healthiest based on what the question is asking. So, if the question asks, "Who do you discharge?" you should choose the lowest priority or healthiest client. And if the question instead asks, "Who do you assess first?" then you must choose the highest priority or sickest client. Now, as we continue, remember that every priority stem includes 4 components, which are age, gender, diagnosis, and the modifying phrase. And it is the modifying phrase that is the most important. Although age and gender are usually irrelevant, the modifying phrase determines the true priority. And that is why you should not automatically default to the ABCs unless they are clearly indicated. Moving forward, keep in mind the 4 rules of prioritization, starting with the fact that acute beats chronic. And next, that a fresh post-operative client, less than 12 hours after surgery, beats a medical or surgical condition. You must also remember that unstable beats stable, and if there is ever a tie, then the more vital organ wins as the final tiebreaker. As we go deeper, let us look first at the stable indicators, which include that the client is stable, has a chronic illness, is post-operative for more than 12 hours, or received local or regional anesthesia. A stable client may also have A or B level laboratory abnormalities, be ready for discharge, or have been admitted more than 24 hours ago, and they typically present with unchanged assessments and expected signs and symptoms. On the other hand, unstable indicators include when the client is unstable, has an acute illness, is less than 12 hours post-operative, or has received general anesthesia. An unstable client may also have C or D level laboratory abnormalities, be newly admitted or newly diagnosed, or have been admitted less than 24 hours ago, and their condition usually shows changing assessments and unexpected signs and symptoms. Finally, always remember not to confuse severity with unexpected findings, because a high-severity condition that is expected becomes a lower priority, while a low-severity condition that is unexpected becomes a higher priority. A classic example of this pattern is that mild chest pain is prioritized over severe kidney stone pain simply because one is unexpected while the other is expected. Let us begin by reviewing the conditions that are considered always unstable. And first, I want you to remember that hemorrhage, and not just simple bleeding, automatically makes any client unstable. As we continue, a high fever above 105 degrees Fahrenheit becomes a critical concern because it significantly increases the risk of seizures. Moving forward, hypoglycemia is also an unstable condition because the brain cannot function without glucose. Finally, pulselessness and breathlessness are included here as well, although they become the lowest priority only when they are found at an unwitnessed accident scene. Now, let us look at the black tag criteria for an unwitnessed accident. And here, we say to tag a client black and manage them last if they are pulseless. Along with that, they must be managed last if they are breathless. And in addition, when pupils are fixed and dilated, indicating probable brain death, they also meet black tag criteria. When you are dealing with a tiebreaker scenario in triage or prioritization, the order of organ vitality becomes important, and at the top of this order is the brain. Next in importance are the lungs. Following the lungs, the heart comes next. After the heart, the liver takes priority. Then we look at the kidneys, and finally the pancreas is last in the organ vitality sequence. Now let us shift to delegation by reviewing what must not be delegated to a registered practical nurse, and we start with the fact that they cannot be assigned to start an intravenous line. They also cannot hang or mix intravenous medications. Another restriction is that they cannot push intravenous medications, although they may maintain or document the flow. They must not administer blood or handle central lines, and that includes flushing them. They cannot plan care. They must not perform or develop teaching, although reinforcing teaching that already exists is allowed. They must not care for unstable clients. They must not perform the first of anything, whether it is an assessment, a task, or teaching. And finally, they cannot handle admission, discharge, transfer, or the first assessment after a change in condition. As we move on to what must not be delegated to nursing aides, remember that they cannot chart about the patient except to document only what they themselves performed. They also cannot administer medications except for topical or over-the-counter barrier creams. They cannot perform assessments except for vital signs and blood glucose checks. They cannot perform treatments except for enemas. And when it comes to catheterization, we must be cautious and select it only if there is absolutely no other option. Let us begin by reviewing what tasks can be safely delegated to aides. And we start with the understanding that activities of daily living such as bathing, grooming, toileting, and feeding are appropriate for delegation. Next, it is important to clarify that aides may not perform the first assessment of anything, because the initial assessment always belongs to the licensed nurse. Moving forward, we add the extended care exception, which explains that in long-term care, registered practical nurses may perform tasks that are typically restricted because the population is stable. Now, let us shift to a critical rule, which is that safety is the nurse's responsibility. From this, we emphasize that you cannot delegate safety to family members under any circumstance. Continuing with this idea, you may delegate to trained sitters only after teaching them and documenting that they are competent. Finally, if a family requests restraint removal, it is not allowed, because safety decisions must remain under the nurse's authority. As we move into staff management, the first priority is to evaluate inappropriate staff behavior whenever it appears. From there, we remember that there are 3 possible actions, and ignoring the behavior is never appropriate. The first option is to tell the supervisor. The second option is to confront the staff member immediately, and if necessary, take over the situation. The third option is to discuss the issue at a later time. Now let us strengthen this framework with decision questions, beginning with, is the behavior illegal? If the answer is yes, you tell the supervisor. If the answer is no, you move to the next question. The next question asks, is anyone in immediate physical or psychological danger? If the answer is yes, you confront immediately and take over. If the answer is no, you continue to the next question. The final question asks whether the behavior is legal, not harmful, but still inappropriate, and if the answer is yes, then you address it later. To conclude this section, we highlight a special rule for situations that are both illegal and harmful. In such cases, you must confront and take over immediately to ensure safety. Once the immediate danger is controlled, then you inform the supervisor as the next step. As we begin exploring point-and-click questions, it is important to remember that you must be able to identify anatomical quadrants and organ locations. This is essential because NCLEX increasingly includes point-and-click items. And to handle these confidently, you need to know the precise surface landmarks used in assessment. Now moving into abdomen quadrants, you may encounter questions that require identifying which quadrant an organ lies in. And this means you must ensure accurate quadrant recognition for proper assessment and pathology. Next, when it comes to heart valve auscultation, exact auscultation sites must be known for the NCLEX. And as you practice this, remember to use the diaphragm or the bell as appropriate for valve sounds. Continuing with auscultation locations, the aortic site is found at the second intercostal space at the right sternal border. The pulmonic site is located at the second intercostal space at the left sternal border. The tricuspid site is positioned at the fourth intercostal space at the left sternal border. And finally, the mitral site is at the fifth intercostal space at the mid-clavicular line, which is also the apical pulse site. And as we finish with peripheral pulses, remember that these include the carotid, the radial, the brachial, the femoral, the popliteal, the posterior tibial, and the dorsalis pedis. As we move into these NCLEX microsafety reminders, remember that every small action can have a major impact on client outcomes. First, palpate one carotid artery at a time because doing both together can decrease cerebral perfusion. Next, always compare peripheral pulses bilaterally for symmetry so you can immediately identify any differences. And finally, understand that the dorsalis pedis pulse may be naturally faint, so if it is not palpable, simply use a Doppler. Now, let us look at some key test-taking tips that will help you stay confident during the NCLEX exam. Expect to do guessing on the test, because this is completely normal with computer adaptive testing. When it comes to how to guess, begin by using your knowledge first so you can narrow options logically. Then apply common sense to rule out unsafe or unrealistic choices. And only use a guessing strategy when it is truly needed. Next, let us go over guessing strategies specifically for psychiatric questions. If you are completely unsure, choose the option stating that the nurse will examine their own feelings about the situation because this prevents countertransference. Another strong choice is to establish a trust relationship, which is essential in psychiatric care. And always remember to apply safety first, such as when a client is approaching with a weapon, where prioritizing safety becomes the immediate concern. Now shifting into nutrition and food guessing strategies, here is how to approach ties on the exam. In a tie, pick chicken as long as it is not fried. If there is no chicken available, then pick fish, but not shellfish. Never pick casseroles for children because they are generally unsafe options. Never mix medication into children's food. And for adults, you should ask permission. Toddlers should be offered finger foods to support their developmental needs. And preschoolers should be allowed independence, remembering that one meal a day may occur at this age. And now, let us finish with pharmacology guessing strategies. The most common NCLEX focus is side effects, which means you do not need to memorize dosages, routes, or frequencies. If you know the drug action but not the side effects, then choose a side effect from the same body system. If you do not know the drug at all, and it is given by mouth, then choose a gastrointestinal side effect. And finally, never tell a child that medicine is candy. As we begin with guessing strategies for obstetrics, remember that check fetal heart rate is often the priority. And that simple idea can guide many NCLEX questions when everything else seems equal. Now moving into medical surgical guessing strategies, the first thing you assess is the level of consciousness. And following that principle, the first thing you do is establish an airway, which keeps you aligned with safety and priority sequence on the NCLEX. Shifting our focus to pediatric guessing strategies, the growth and development principle reminds us to always give the child more time. And from there, we follow the 3 rules. When in doubt, call it normal. And when in doubt, pick the older age. And when in doubt, pick the easier task, because these reflect predictable developmental patterns. As we expand into general guessing skills, remember to rule out absolutes, because they are rarely correct unless they relate to safety, such as the example, never push intravenous potassium. If 2 answers say the same thing, both are wrong, and if 2 answers are opposite, one is likely correct. Finally, with the umbrella strategy, choose the most global answer that covers the others. And finally, when approaching priority questions for one client, remember that when choosing the highest priority among 4 correct needs, you must think about the worst consequences if the need is not addressed, and then select the option with the most serious potential outcome. When you are stuck between 2 answers, the first thing you should do is reread the question, because the clue is usually right there. Now, let us move into the Sesame Street rule, which you should use only when all else fails. This rule simply reminds you that 3 of these things is not like the other. The correct answer tends to be the most different. Wrong answers often look similar because they share the same incorrect element. Next, let us talk about why you must avoid ignorance-based answering, meaning you should base answers on what you know and not what you do not know. When you remove the unknown parts of the question and focus on the known concepts, you will find the question becomes much easier. Use common sense, because the NCLEX tests reasoning. Moving forward, you also need to learn to trust your gut. If something seems right, it probably is. Go with your first instinct. Change your answer only if another option is clearly superior. Finally, understand the expectations you cannot have, because unmet expectations lead to increased stress and poor performance. Let us begin with expectation A, which is that you should not expect 75 questions. Instead, be prepared for 250 questions. Reaching 200 questions does not mean failing, because the test would have shut off earlier if you were failing. Now moving into expectation B, do not expect to know everything. The computer adaptive format purposely gives unfamiliar items, and your job is simply to focus on what every nurse must know.